Hello, Miss Vo and First Five. Can everybody hear me?
Yes, good afternoon, Madam Chair.
Thank you. Um, have you called roll? Do we need to call the meeting to order?
Yes, we'll call roll right now.
Thank you.
Maricela Ramirez,
Here.
Alma Cortez, here. Priya Batra,
Here.
Astrid Hager, Abigail Marquez, Summer McBride,
Here.
Brandon Nichols,
Here.
Carol Sagala,
Here.
Justin Blakely,
Here.
Robert Byrd,
Here.
Deanne Tilton Durfee, Jacqueline McCroskey,
Here.
and Holly Mitchell.
And I'm present.
Quorum is present.
Thank you very much. Colleagues, I'm joining today's meeting remotely under the provisions of SB 707, and I'm utilizing the just cause exception due to work-related travel and official business obligations on behalf of the Board of Supervisors. So thank you. Moving on to agenda item 3, a report out from closed session.
Yes, Chair, thank you. So there were two closed sessions earlier today, one of the Executive Committee and one of the full board, both on the same topic, which is related to public employee performance evaluation for the President and CEO. There was discussion in both closed sessions, but no reportable action was taken in either.
Thank you. Just a quick question for me before I go on to my remarks. Is it possible to change the order of the agenda? Can we take the vote before we hear the CEO's report, Council?
Oh, yes, certainly. If the,
Okay,
if
great.
if the board is, the full board is okay with that.
Is there any opposition to
I don't see any, Chair.
okay, excellent. Thank you. So thank you, everyone. Good afternoon. I appreciate you all for being there today. I'm sure it was pretty exciting over there in Union Station, given World Cup is exciting all over LA County. And so we should get ready. It feels like we've been talking about it was coming forever, and now it's here. I want to use just a little bit of time today to acknowledge, that I'm not going to be able to stay the full board meeting because of my county work duties, but I did want to pause to say some heartfelt thank yous to my county family member, Commissioner Brandon Nichols, for his willingness to serve as vice chair. You never shy away to when called upon to step into leadership, and for me that is an absolute reflection of your deep commitment to the lives of LA County's children and families. And so, Brandon, you know how I feel about you and your work here at the county, as well as what you brought to the First Five Commission. I'm grateful for your service and partnership. For me, I have entered the season apparently of retirements and transitions. And so I wanted to acknowledge you very publicly for what you've brought to First Five. I'd also like to thank Commissioner Ramirez for her 4 years of service on the board. You too, as you know, everyone on the board, but you also in terms of your tireless advocacy for children and families, educational equity, and your deep understanding with regard to the needs of young children have impacted all of us, the work we do, and it will be a part, in my humble opinion, of your lasting legacy here at First Five. And so I appreciate you both. If either of you would like to say a few words, if there are other commissioners who would like to also express their appreciation for your service, we are open to do that. And I will need some help because you all are a tiny box. I can't see who's there. So Carla, if you could just
Yes.
manage the room and calling on people for me.
Well, I'll just say quickly, it's been a privilege to sit here in fellowship with you. Love the First Five staff, love the work that First Five does. The mission is dear to my heart. I've spent 30 years doing it. I'm I feel very lucky to have been here. I just want to say thank you all, and thank you to the supervisor for the kind words.
Well, thank you for this opportunity, and I also want to say thank you. Thank you to all of you, all the commissioners and all the staff members. It's been an absolute privilege to be able to be here, especially in recent years when our social institutions are under attack. It was always inspiring, and I've learned so much from everybody here, so thank you so much. The next leg of my career, I will be the assistant superintendent in Culver City, and I am so excited to continue to serve children. I look forward to being in partnership with all of you still. Thank you. It's been a real privilege.
Thank you. And Chair, we do not have folks raising their hands right now, but during my comments, we'll bring some team members, so we could hold off on comments right now.
I appreciate that, and I'm glad to know you'll be in Culver City. That means you're still stuck with me. Lucky you, Commissioner. Okay, with that, do I need to open it up for a public comment on the chair's report?
Yes, and I'm confirming there are no public comments on the chair's report.
Got it. Thank you very much. Again, I'm going to go slightly out of order on the agenda. I'm going to move up the election. So we're moving now into agenda item 6, election of the vice chair of the commission. As we continue the important work before this board, it's essential that we maintain strong leadership and continuity. And with that in mind, I'd like to nominate Commissioner Summer McBride to serve as vice chair of the First 5 LA Board of Commissioners. Commissioner McBride has been a dedicated advocate for children and families and has consistently brought valuable insight, leadership, and commitment to our work. I'm confident that she will serve the board well in this role and help advance our shared goals for young children across LA County. It has been customary in the board that the vice chair has been the appointee of the chair, and we have kind of deviated from that sometimes, but I'm proud to say that Commissioner McBride is the appointee from the 2nd District. I'd love to have a second for my nomination, please.
You have a second.
Thank you. At this time, I'd like to call for a vote to appoint Commissioner Summer McBride as vice chair of the First 5 LA Board of Commissioners. Ms. Vo, will you call the roll for me?
Maricela Ramirez,
Yes.
Alma Cortez,
Yes.
Priya Batra,
Yes.
Astrid Hager,
Yes.
Abigail Marquez,
Yes.
Summer McBride,
Yes.
Brandon Nichols,
Absolutely, yes.
Kara Sagala,
Yes.
and Holly Mitchell.
Yes.
Congratulations, motion is passed. Summer is our new vice chair.
And with that, I'm going to, have you all seen the IG where you pass the mic this way and the next person sings? So I'm passing the gavel
I'm taking it.
to newly minted Vice Chair Summer McBride. Thank you very much.
Thank you, Supervisor. And thank you all for giving me this opportunity to serve another term as your vice chair. And thank you to Commissioner Nichols for being in this role for a short while since when you returned. And I just want to thank both of you, Commissioner Nichols and Maricela Ramirez, for everything that I've learned from you serving with you on this board. So thank you. With that, I'm going to turn it over to our President and CEO for her report.
Fantastic. Good afternoon. Very, very thrilled to continue this love fest for our two commissioners. So I want to invite some of our team members to share some of their gratitude for the work that you have done. I will welcome J.R. Nino first.
Good afternoon, Commissioners, and this is for you, Commissioner Ramirez. So it is my honor to recognize Commissioner Maricela Ramirez as she concludes her service as our board member with First 5 LA since 2022. A little bit about Commissioner Ramirez. She is an educator. Congratulations, by the way, for your new role. An equity-focused educator who believes education is critical, and she works tirelessly to ensure that students of all ages have access to a quality education. So during her time with First 5 LA, Maricela Ramirez has been a steadfast leader, bringing both vision and heart to our work on behalf of our young children and families across LA County. Throughout her years of service, she has demonstrated unwavering dedication, thoughtful guidance, and deep commitment to equity and impact, most recently as our chair for our Budget and Finance Committee. So thank you, Commissioner. Maricela has guided critical decisions with integrity, clarity, and fiscal stewardship, ensuring that our investments are aligned to our strategic plan within our fiscal reality, and influencing our long-term financial plan, which we are using today. Her leadership has strengthened this organization and advanced our mission in meaningful and lasting ways. We deeply grateful for your contributions and the legacy you leave behind, Commissioner. So thank you for your service, and we wish you all the best, and congratulations again for your new role.
And now if we could invite Aurea up for a few comments.
Good afternoon, Commissioners. I am honored to recognize Commissioner Brandon Nichols for his outstanding service to First 5 LA as a board member also since 2022. Commissioner Nichols, First 5 LA has benefited tremendously from your remarkable career with LA County, from your vital work with probation, with the County Board of Supervisors, your leadership as Chief Deputy Director for DCFS, and most recently as Director of the Department of Children and Family Services. Your expertise in child welfare, foster care, and mental health is truly unparalleled. And beyond your impressive background, what has impacted us the most is your huge heart. And so some, similarities with our esteemed Commissioner, Dr. Ramirez. We have been profoundly moved by your love, your passion, and your unwavering dedication to LA County's children. You have fiercely prioritized the safety. You've advanced racial equity, and you've championed the high-quality support for families. You have consistently put children and families at the center of all of your engagement on this commission. You've helped to shape the direction and our strategic plan. And you've created opportunities for us to partner more deeply with the Department of Children and Family Services and with the departments across the county that are really focused on prevention. We know how demanding your time is as the head of DCFS, and still you made time to come prepared to really lead with visionary leadership on this commission, and most recently as vice chair for the commission. So we're deeply grateful for your time, for your wisdom, for your energy, and all that you have given to this commission. And, we're super excited for you that you get to enjoy time with your family, and after working so tirelessly for all of the children in LA County. So we wish you the very best in all of your endeavors. Thank you.
I will just echo, thank you, Aurea. I will echo Commissioner Nichols. You have completely changed the DNA of DCFS. I don't think folks know how many Angelino families you actually provided hope in some of the most trying times. So thank you to you. And Commissioner Ramirez, thank you for pushing us on impact. We talk a lot about gaps, and she said, nope, that's not enough. What's actually going to change in the lives of children? You both have made us so much better. And the team got a small token of appreciation that we're pulling for you. It's It symbolizes the seeds that you have planted for First Five LA, and beyond the time you are here, we will continue to grow because of the seeds you planted for all of us. So the team will bring forward. Thank you, Linda. Thank you, Hannah.
We'll be blooming in there. How lovely.
With that, we'll say thank you, and I hope that you all know how deeply, deeply you're appreciated. So thank you. And now I will make an awkward transition to business and purpose of our meeting today. So let me start with what we are navigating. We all know we're living in complex times. We'll not share all the things that you read about what's happening during these times. In these times, what we continue to talk about is what you see in front of you, our vision, mission statement, and it is we continue to focus on children and families in complexity and in nuanced times. This is our mission, and we will continue to make sure that we center children and families in the work that we do. That mission has not changed, and from now until the end of the year, we will continue to talk about our fiscal reality and what's happening given fiscal reality. If we go to the next slide, please. A little bit of history, and it just merits repeating because fiscal reality is something that's happening outside the external control of this commission, of First Five LA. And the history is that First Fives were created to advance innovation and target funding for children 0 to 5. And the way we, California, have been able to fund that is through an incredibly innovative tax policy that said we will tax tobacco products, and the revenue that comes out of that will go to every county and managed through First Fives. The idea was if we tax tobacco products, folks will start smoking less. It is remarkably innovative. It has worked. Folks have, in California, smoke a lot less. And what you see on the screen, it just has meant that we knew there was going to be decline in revenue. So this is a story that we knew going into it. However, what we did not know was a new proposition passed in 2022. And if we go to the next slide, please. What this did was basically create a bump down for fiscal reality. So we knew there was decline in revenue. The organization had been planning for some of that, but we did not know about Proposition 31. And basically there was less revenue coming in because we would not tax certain tobacco products. So at the time, we saw early warning signs. We knew there was going to be a fiscal reality that would create unnecessary fiscal cliff. And what I've shared with this board, what I've shared with folks in the audience with our team, other First Fives faced bankruptcy. Other First Fives saw the fiscal cliff much sooner than what First Five LA experienced. And at that time, our finance team brought a really important decision, choice, I should say, for the board. We could continue operating exactly as we were operating and eventually face a fiscal cliff, or we could confront that reality and really deliberately think about our long-term sustainability to make sure that we continue to support grantees. And at that time, if we go to the next slide, please, this board chose stewardship. And basically, together we established what you see on the slide, and it was a prudent, strategic glide path that had step downs instead of a fiscal cliff. And that step down had us stabilizing for our community partners at $60 million. Board, this is what we have been doing. We have been managing these strategic step downs for the last several years. And in doing that, the organization is functioning at times as if we are a $140 million organization, because that's how it was structured. It takes time to look at structure of an organization. It's a mismatch operating at those levels and the reality of what we have to face. So our work for this year through and upcoming years through the budget process is to build that $60 million organization for the future. So we're in this area where we are building a new reality for the organization. Today, our meeting will really focus on this fiscal reality, and specifically, it will focus on some of our largest investment at the organization, and that is home visiting. I want to begin with home visiting by acknowledging two realities that often feel they're competing with each other, and the conversation with the board is to really spend time in that gray. One reality is home visiting creates remarkable value for children and families, for communities. It has been an important part of First 5 LA's work and remains a really critical strategy. That is a reality. And the other reality is our fiscal reality. It really requires us to make difficult decisions. And as First 5 LA transitions to a longer-term budget of approximately $60 million, we cannot sustain a $28 million home visiting investment. Continuing at that level would not only be financially irresponsible, it would actually limit our ability to advance other priorities. And we have had discussions in the organization that we have to balance having innovation, keeping some of the programs that we know really, really work. So let me be clear, First 5 LA is committed to home visiting. What we have to make sure we're navigating is that if anyone thinks we are not committed to home visiting, that is not what we're saying. What we are saying is we need to balance it to our fiscal reality. So as we consider the next phase in the conversations had at this board for evolving that program and right-sizing the work, there are three really important strategic anchors that we are using that the board has provided. First and foremost, it is our strategic plan. It's the big board. Those goals are not changing. Those objectives are not changing. So that's one really important parameter that we're working with. The second, the board has endorsed the equity index. We have said we are going to target all our resources to highest need communities, and the way we are defining it is through an equity lens. We are looking at racial disparities, poverty disparities, regional disparities, and that's where we are going to target resources. And then lastly, the strategic anchor is our long-term financial plan. At a $60 million organization, we have to be really clear-eyed that the investment for this needs to be right-sized really significantly. So with that, I do want to provide for folks in the audience, for our partners that are leading some of our home visiting work, are working with county also on home visiting. I want to speak to you really, really directly. We know that these conversations are really, really difficult. We know that it creates uncertainty, and no one in this organization or this dais is taking that lightly. We know this is difficult to navigate, and you deserve honesty, you deserve respect, you deserve transparency. And that is why we have brought these conversations to public settings, so that we are all hearing the same thing. As we transition to a smaller sustainable budget, we simply cannot maintain home visiting at the current scale. That reality is really difficult, but it is really important for us to be honest with you. At the same time, we know that you have learned so much over the decade, given what work you are already doing, and we want to learn from that. So we really invite public comment. We really invite folks to connect with our team members, share, here are the best practices that show the outcomes that we want to see for young children aligned to the strategic plan. Part of it is a strategic imperative that we have to make sure that we're paying attention to. While community input is really, really important, we are going to be looking at our fiscal reality. So please join us for these meetings, provide us with your input, and help us understand how we make sure that the right sizing of this investment is something that will have the greatest impact on children. So with that, I will turn it to Vice Chair McBride.
Thank you so much. Are there any comments or questions on the President's report? Do we have any public comments?
Confirming there are no public comments on the President's report.
Okay, thank you so much. Moving on to item number 7 on the agenda, which is consent. I'm going to turn it over to J.R. Nino.
Thanks, Commissioners. As we pivot to the consent agenda, we normally don't make comments regarding this, but today there are a little bit higher number of contracts coming to you today. A good number of these contracts are renewed on an annual basis. There are 43 agreements that are new or anticipated to renew in July 2026. There is a memo included in your board packet that shows the breakdown of these 43 agreements. And just in summary, 23 of them are subject to board approval, which is why we're bringing it up here today. And per the procurement policy, they are greater than 150K in aggregate. So that's why they're coming to the board today. 11 of them are less than 150K, so that is within our President and CEO's authority. And finally, 9 of them are actually covered within our strategic partnership memos later in the agenda under items 9 and 10. That one particular item, 10, which is to establish a strategic partnership with Shields. Want to kind of signal that right now, having this opportunity to talk about it. That's for continuity of services for the Welcome Baby program. Per the board-approved governance guidelines, agenda items regarding commission actions will be first introduced as information at a full commission meeting prior to action in a subsequent meeting. So First 5LA is requesting to waive those guidelines as it's coming to the board today for action. Again, it is to establish a strategic partnership with Shields for families in the amount of $809,513 through June 30th, 2027. Funding will allow Shields and families to continue Welcome Baby program services for the SPA 6 families, one of the highest needs areas in LA County. Okay, so I wanted to signal that for item 10. Going back to consent agenda, also included in your board packet for item 4C is a contracts table listing of all the 23 agreements new and anticipated to renew. The listing contains contract, project information, the office and teams who own them, the project, and as well as tracking the satisfactory progress of the actual contractor or vendor for those. So I, along with the staff, are here to answer any questions. Again, just pointing out that there's a higher number of renewals today, which is why we're bringing it up for the board today.
Thank you so much, JR. Commissioners, do you have any questions about item 7 on consent? Do we have any public comments?
Confirming there are no public comments for the consent items.
All right, may I have a motion to approve consent, which includes items 7A through 7C?
I'll move.
Thank you. Is there a second? I second. Thank you. May we have roll call?
Maricela Ramirez,
Yes.
Alma Cortez,
Yes.
Pia Bacha,
Yes.
Astrid Hager, Abigail Marquez, Summer McBride,
Yes.
Brandon Nichols,
Yes.
and Kara Sagala.
Yes.
Motion is passed.
Thank you so much, JR. Moving on to item 8, which is just an information item in your packet and in the agenda, if you happen to be following online, is the Board of Commissioners Committee assignments for 2026. I'll just read them as they're listed here. Board Supervisor Holly Mitchell, Chair; Summer McBride, Vice Chair; Executive Committee, Summer McBride, Chair; Alma Cortez, Vice Chair; Carol Segala, part of the Executive Committee; Program and Planning Committee, Summer McBride, Chair; Carol Segala, Vice Chair; Barbara Ferrer, Jacqueline McCroskey, Deanne Tilton; and Budget and Finance is Alma Cortez, Chair; Abigail Marquez, Vice Chair; Luis Batista, and Astrid Hager. If you want to keep record of that, it's in your folder. Are there any questions about the assignments, the committee assignments? Are there any public comments on that item?
Confirming there are no public comments on this item.
Okay, thank you. Moving on to item 9, which is an action item, and I believe I'm turning it over to Deanna for, is there going to be a presentation for this, or are we just reviewing? Okay, all right. So item 9 is approve amendment of the strategic partnerships with 8 hospitals in Los Angeles County in the amount of $14,314,284. It's all of the information is on your packet, in your packet. Ms. Vo, does anyone have any questions before we go any further? No? Do we have any public comments on item 9?
Confirming there are no public comments for item 9.
Okay, may we have a motion to approve?
I'll move.
Moved by Commissioner Nichols. Is there a second?
Second.
Thank you, Commissioner Batra. May we have a roll call?
Maricela Ramirez,
Yes.
Alma Cortez,
Yes.
Priya Batra,
Yes.
Astrid Hager, Abigail Marquez,
Yes.
Summer McBride,
Yes.
Brandon Nichols,
Yes.
and Carol Segala.
Yes.
Motion is passed.
Thank you so much. Moving on to item 10, which is also an action item provided as a written report available for review. All supporting materials were provided in the publicly posted board book. Do we have any questions from commissioners? Ms. Vo, do we have any public comments?
Confirming there are no public comments on this item.
All right, may we get a motion to approve item number 10? Thank you, Commissioner Marquez. Is there a second?
Second.
Thank you, Commissioner Batra. May we have roll call?
Maricela Ramirez,
Yes.
Alma Cortez,
Yes.
Priya Batra,
Yes.
Astrid Hager, Abigail Marquez,
Yes.
Summer McBride,
Yes.
Brandon Nichols,
Yes.
and Carol Segala.
Yes.
Motion is passed.
Thank you so much. I don't know about you, but the energy is low. I have not had coffee today, so please forgive me if I'm the problem. I just sense that there's low energy. Right now, we're going to have an information item, the May Revise and Legislative Priorities Review. It's a written-only item. The report today is submitted in writing and available for review. All supporting materials were provided in the publicly posted board book. Ms. Vo, are there any persons who wanted to make public comment about item 11?
Confirming there are no public comments for item 11.
Okay, thank you. I didn't ask if there were commissioners that had questions. I apologize. Are there any commissioners who have questions on item 11? Okay. Moving on to item 12, the finance update. For item 12, let's prepare to hear the finance update from our presenters and approve the fiscal year 2026-27 proposed budget and updated LTFP and resolution 2026-02. Being presented by our incredible finance team, J.R. Nino, VP of Operations and Sustainability, Raul Ortega, Director of Finance, and Daisy Lopez, Manager of Financial Planning and Analysis.
We'll get the
Maybe
party
you can bring the
started.
energy.
We'll bring the energy.
All right.
Bring the energy.
We'll start with this. Good afternoon, Commissioners.
Good afternoon.
Thank you. Getting right into it, last month we presented next fiscal year's budget for information, and today we're presenting it for action. Rolo, Daisy, and I will give a brief recap and next steps. As a reminder, Carla also went through this earlier today. Building upon Carla's comments, I talked about the big picture, where we've been and where we were, and where we're going from a fiscal perspective to help frame next fiscal year's budget. To add to Carla's comments, this environment has required us to take that strategic, disciplined approach, not only how we manage our budgets year to year, but in how we plan thoughtfully for long-term financial sustainability. Importantly, our long-term financial planning efforts began early as a proactive measure to mitigate challenges well before the more recent federal actions and budget reductions that are now furthering our impact of the broader landscape. 3 years ago, the board adopted a strategic tip-down approach, having us at $70 million next fiscal year, and ultimately, as Carla mentioned, towards stabilization at $60 million starting in fiscal year 27-28. As we move towards stabilization, we've taken a number of deliberate steps to operate with greater efficiency, discipline, and focus. The following has guided our work, again, building upon and reinforcing and underscoring Carla's comments. We are consistently reviewing our investments to ensure they're tied to our strategic priorities and our strategic plan. We are deliberately scaling our budgets to match our long-term financial outlook and our long-term financial plan. Transparent partner communications, we have prioritized clear and proactive communications with our partners. As Carla mentioned, we are committed to innovations. Our fiscal reality has required us to innovate to identify more effective, scalable, and sustainable approaches. And finally, equity remains central in informing where and how we target our resources, ensuring investments are directed to areas of highest need. Finally, last month, we also highlighted these particular areas of the sustainability framework. As a friendly reminder, on the left, we have accomplished leasing a portion of our building for additional revenue. And over there to the right, we are continuing our collective impact efforts, where we are partnering with other organizations for additional revenue sources. So again, this was a quick recap from what we went through last month. I will now turn it over to Raul Ortega.
Thank you, JR. And wow, we're here to take an actual vote on the proposed fiscal year 26-27 budget. And let's just say it, $70 million. We're going to make a huge impact, so we need to be celebrating that. Thank you, JR. So let's go through the budget. We're going to just do a quick recap on where we're at with the overall budget. As you recall, last month we did provide an overall information item where we went a little bit deeper into the proposed budget, where we are investing our resources within our programs and also within our operating budget. And then I will do a quick overview of what the updates were to the long-term financial plan, which is mostly housekeeping, and then I will pass the agenda to Daisy to really go through the actual resolution. So let's go into the proposed 26-27 budget. And before I move into the actual numbers, I just really want to celebrate and acknowledge both Commissioner Ramirez and Nichols. You guys have both played critical roles in supporting myself and my staff within the finance department, but really your support within the Budget and Finance Committee. Your role is very critical to our success, so I just really, on a personal note, want to just call out that appreciation for the hours and the time that you guys have invested in supporting this. So thank you on behalf of myself and my staff within the Finance Department. And here, we're going to celebrate your hard work with us, and that is the actual passage of the $70 million budget that's before you. Just to call out, at a high level, we are investing a total of $53 million in programs. That breaks down into our Center for Family Systems and Human Resources. Mostly our family support investment is roughly $29.4 million. That is an overall reduction from the prior year of roughly 8.1%. In the area of community, for the Center of Community and Engagement and Policy, Our total proposed budget for the upcoming year is roughly $18.4 million. That's roughly a 13.8% reduction from the current year's budget. And then for our Center for Strategy and Culture, we are landing at roughly $1.25 million. That's what we are proposing, which that brings a total reduction from the prior year of 16.3%. So when you look at our total investment in supporting our strategic plan work, that comes out to roughly $49.1 million, which is an overall reduction of 10.6% to the current budget. Also included within the budget that's before you is the Strategic Initiative Development Fund. Again, that comes to a total of $3.9 million, which is a 16.8% reduction from the current year's budget. Again, the Strategic Initiative Development Fund is primarily used in innovation of the current work that is identified within the strategic plan. There's also resources available within that line item to be responsive to federal response and things that are coming out from our friends at the federal level. Question mark on friends. And in case of emergency response, if there's any type of emergency within LA County, that we could be responsive and support our 0 to 5 family. So that Strategic Initiative Development Fund is really a good opportunity for us as an organization to shine outside of the great work that we're doing and that we are committed to. In support of the program, we also have a total support. When I mean total support is the people that are behind me, the people that are next to me. These are the people that lead the work, create the work, develop the work, monitor the work, manage the work. All that comes out to a total of $7.7 million. We are seeing roughly a 21% reduction in that area. And then we'll land with the admin. This is where I sit, along with my colleagues within IT, human resources, and our contracts and compliance folks. That comes out to roughly $10.9 million. That is an overall 14.1% reduction. All in all, when you look at the $70 million compared to the $80 million, we are seeing an overall reduction of 12.5%. That again, that summarized the total budget that we're proposing and that we're asking you to take action on. Within these resources, our total admin cost comes out to roughly $10.9 million, which makes our admin rate at roughly 15.5%. In addition to the $70 million proposed budget, we are also getting secured funding to offset that $70 million investment of roughly $7.1 million. So the total investment coming out of our fund balance is roughly $63 million. So with that said, I'm going to now pivot to the long-term financial plan. And if I need to slow down, please let me know, because we want to make sure we're all bringing everyone along. So that we can get a positive action from you guys. On the long-term financial plan, again, the board adopted a long-term financial plan back in October of 2024. What's before you is really more of housekeeping. These are the areas where we have to update on an annual basis so that we can continue to monitor our long-term financial strategy and to help guide this commission and our executive team on making decisions on where resources should live. So with the update of our long-term financial plan, it's really where we have actual information, meaning where we used to forecast and now we have actual data, we update. So for an example, for fiscal year 24-25, we now have actual expenditures, so now we can pivot from what we thought was a projected budget to now actual expenditures. That has a rolling effect to what our remaining fund balance looks like at the end of 34-35. In addition, we update information like what we're at today, by updating what we have in the budget column to the actual mid-year. Obviously, at mid-year, we didn't make any changes, so it still reflects the $80 million that we have approved. And then for the 26-27 column, we're now updating it to the proposed budget that's before you. In addition, other updated areas are the projected and estimated revenues. That is the Prop 10 tobacco tax revenue that gets updated on an annual basis. In addition, we were also able to update the long-term financial plan to reflect the new 7-year lease of the second floor, which has significantly changed our projected fund balance for the end of fiscal year 34-35. So then, with that said, our new projected fund balance for 34-35 is now estimated to be roughly $88 million. And with that high-level review from last month's presentation, I'm now going to pass it to Daisy to walk through the actual next steps and to walk through the resolution so that the board could take action. And again, thank you for your time. Commissioner Ramirez and Nichols, again, thank you for your support and your dedication to the Budget and Finance Committee and to the Finance Department. Thank you.
Thank you, Raul, and I will echo that. Thank you, Commissioner Ramirez and Nichols, for all of your support and dedication. So looking ahead at next steps, last month we shared materials and presented the fiscal year 26-27 budget and updates to the long-term financial plan to the combined budget and finance and executive committees, followed by a presentation to the full Board of Commissioners. Today we provided a brief overview and highlighted key elements of the final fiscal year 26-27 budget and updated LTFP for your consideration and approval. Today's item does require a recorded vote by the board, but before I turn it back over to our vice chair for questions and discussion, I would like to summarize the actions that are being requested. So we are requesting approval of resolution number 2026-02, which includes the following actions. Superseding the prior resolution approved in June 2025, adoption of the fiscal year 26-27 budget of $70 million, approval of the administrative cost limit of $10.9 million or 15.5%, reaffirmation of GASB 54 constraints or the classification of our fund balance amounts with committed funds totaling approximately $53 million. So this amount in committed dollars will be affirmed through the audit process, which will be shared with the board for information in September and approval in October, or action in October. We are also requesting the maintenance of our fund balance reserve of 50% of $35 million for fiscal year 26-27, and formal assignment of the updated future funds through the LTFP through fiscal year 34-35. So an executed copy of the resolution shall be retained on file. All materials pertaining to these requests are included in today's board materials. I would like to extend our sincerest and deepest thanks to staff, leadership, and board members for your time, your feedback, your commitment, and your partnership throughout this budget development process. So at this time, we respectfully request approval of Resolution 2026-02. Now back to you, Madam Vice Chair McBride, for questions, comments, and board vote.
Well, thank you so much for this presentation and for all of the work that you do, not only this year, but throughout the last couple of years that we've been having these conversations about the LTFP and what the projections would look like and the changes that we would have to make in order to meet the moment while still serving the populations that we serve. And I know it's not easy. We've all been a part of these conversations, but this is the work that we've all signed up to do, and I'm appreciative to be able to do this work with you. I want to open it up for commissioners who might have questions or comments. All right. Ms. Vo, do we have public comments on item 12?
Confirming there are no public comments on this item.
May I have a motion to approve item 12, which includes the proposed budget, updated LTFP approval, and approved resolution 2026-02?
I'll make that motion.
I have a motion and a second right there. Commissioner Segala motioned, Commissioner Ramirez seconded. Do I have that correct? All right, may we have a roll call?
Maricela Ramirez,
Yes.
Alma Cortez,
Yes.
Priya Batra,
Yes.
Astrid Hager, Abigail Marquez,
Yes.
Summer McBride,
Yes.
Brandon Nichols,
Yes.
and Carol Sagala.
Yes.
Motion is passed.
Thank you so much. Thank you. I appreciate all your hard work, and I have coffee now, so maybe the energy will start to pick up. Thank you. As we transition for the next item, we are moving on to item 13. We have a receive and file for First 5 California's report. I would like to officially open up this public hearing. With that, we will hear from our presenter, Hari Kim Han, Data Strategy Specialist. Hello.
Hello, good afternoon.
Good afternoon.
Just wait for the presentation, but while we're waiting, I'll introduce myself. Good afternoon, commissioners, staff, and members of the public. I am Hari Kim Han from the Impact and Accountability Department, and I am here today to present First 5 California's fiscal year 2024-25 annual report for the board's review and receipt and filing. All right, so today's public hearing fulfills the annual requirement to review and receive and file First 5 California's for fiscal year 2024-25 annual report. Under Proposition 10, county commissions are required to hold a public hearing at least once a year to review First 5 California's annual report. And today we'll briefly review and highlight selected statewide findings from the report and then conclude the fiscal year 2024-25 annual reporting process. So under Prop 10, county commissions submit an annual report each fall, including information on revenue and expenditures, populations reached, evaluation findings, and county highlights. You may recall that the Impact and Accountability Department presented First 5 LA's first fiscal year 2024-25 annual report data to the board last September, and the board approved submission of the data in October. First 5 California then prepares a statewide annual report that includes information from the 58 county commissions, as well as highlights from state commissions' work, and releases it in the following spring. And First 5 California's fiscal year 2024-25 annual report is included in your board materials. So let's dive into the highlights from the report. Statewide revenues for fiscal year 2024-25 was approximately $1.08 billion. So this amount reflects combined revenue from across First 5 California and the county commissions. Prop 10 revenue specifically accounts for roughly $210 million, or 19% of total revenue, which we are continuing to see a decrease in. The reason for the substantial increase in statewide revenue was largely driven by approximately $618 million received by First 5 Alameda related to Measure C sales tax revenue following the resolution of litigation related to the measure. So this accounts for around 57% of total revenue. The total statewide expenditures were approximately $381 million. So statewide, county commissions served roughly 641,000 children. As context, First 5 LA served approximately 59,000 children. In addition, statewide, First 5 investments reach around 511,000 parents and caregivers and approximately 46,000 providers. In general, this is consistent with emphasis towards systems change, as there has been a decrease in the numbers reached across compared to previous years. The First 5 California annual report also includes highlights provided by First 5 county commissions. These highlights represent various accomplishments and efforts made by the individual commissions during the last fiscal year. The most commonly mentioned themes among these highlights included fiscal sustainability and funding diversification. So these include efforts to reduce reliance on Prop 10 revenue through grants, Medi-Cal, and CalAIM billing, philanthropy, local tax measures, and braided funding strategies. Another commonly mentioned theme is systems buildings and cross-sector coordination. So these include efforts to strengthen coordinated systems of care, referral networks, collective impact partnership, and integrated service delivery. And also, the final highlight that I wanted to point out is a work around home visiting expansion and multimodal networks. So these include implementation or expansion of home visiting models, centralized intake, and regional collaboratives. So last year, we shared that First Five California was updating their guidelines on annual reporting. As a follow-up, the state has revised the guidelines for county highlights and evaluation summary to shift in telling a more comprehensive story of the work than a general update. So this included reporting out on our equity-focused efforts and highlighting counties' commitment to continue progress, innovation, and collaboration. Today's action concludes the fiscal year 2024-25 statewide annual reporting process, and staff will return in the fall with First Five LA specific annual report data for fiscal year 2025-26. And with that, I'll hand it back to the board to open for public hearing before the board considers receiving and filing First Five California's fiscal year 2024-25 annual report. Thank you.
Thank you so much for your report. Are there commissioners who have questions or comments? See, I told you, it's the energy. Do we have any public comments for this item?
Confirming there are no public comments for this item.
All right. If there are no public comments, I believe we can close this hearing. All right. Thank you so much. And again, I don't think it's just the energy. I think it's the hard work of the people who come here fully prepared to present information to us. That's not a surprise because you're constantly communicating and letting us know what's happening. So I really appreciate your time. Thank you. Moving on to item 14. It's an information item on home visiting. And I want to welcome our presenters that have come to share this information. Aurea Montes Rodriguez is presenting. Deanna, who is the Director of Family Supports for First Five LA. Dr. Melissa Franklin. Dr. Shirlene Gozalians. I apologize if I mispronounced your name. Of LA Best Babies Network. And our own Commissioner Priya Batra, who's the Deputy Director of Health Promotion Bureau of LA County. I'll turn it over to our presenters.
Thank you, Vice Chair. Good afternoon, Commissioners. At your request, the next item will be a continuation of the home visiting presentation and discussion from the May board meeting. At the last meeting, we reviewed the results-based accountability framework, and if you remember, we used it to organize the four interconnected questions on the left, and we focused on results and kept in mind the 9 objectives in our strategic plan and our target population. Then we had a presentation from Dr. Charlene Gozalians. She shared data on the populations that are being served by First Five LA's home visiting programs. And Dr. Melissa Franklin, they're both back with us, also presented on the root causes and factors that home visiting program models are addressing, including factors in the larger LA County ecosystem. We then heard from Orange County Director of First Five, Kim Gohl, and from Kathy Eisenhower. They shared about their programs and also talked about some of the challenges, right, in the current home visiting programs and some of the policy and systems change work. Commissioner McBride, Vice Chair, who is also the Chair of the Program and Planning Committee, facilitated a board discussion on these two areas and focused on the first question, for discussion on target populations, on which conditions affecting children and families, First 5 LA can most meaningfully impact through our home visiting investments. There was robust discussion and conversation, and you did ask for us to do a deeper dive or overview of the program models that First 5 LA is supporting, the data that we have on linkages, on retention, on impact, and also the funding or sustainability. And there was some discussion around utilization of the programs, where there might be overrepresentation, underrepresentation, and utilization or underutilization. And so for today, we're not going to cover all of those areas, but we will spend time looking at the data of our existing programs and making sure that there is time for discussion with special attention on the strategies. What are the strategies that we can prioritize in the future direction of our home visiting investments, and what are the outcomes that we should really focus on, right, to demonstrate to the board and to LA County that First 5 LA is making an impact in the lives of children prenatal to age 5. Therefore, we have 120 minutes allocated for this agenda item, including 50 minutes for the board discussion and 20 minutes for public comment. We will look at the target population data, as I shared, and future strategies and results. And want to really allow the time for Vice Chair McBride to have a discussion with all of you around strategic priorities and the outcomes, as I already shared. So moving on to this slide. And actually, before this slide, I do want to reiterate what our President and CEO shared at the beginning, that we are using our strategic plan, 9 objectives, the equity index, and our long-term financial plan, and also the rate of births in LA County, right? And I'll highlight some changes that we touched on at the last meeting. So this slide here looks at First 5 LA's budget in 2009-10, which it was at about $205 million in fiscal year 2013 when home visiting expanded and was being funded at $16 million. By 2015, you can see on the slide, the ramp-up was complete for home visiting with Welcome Baby and Select Home Visiting, and our investment was at approximately $31 million. And then you'll see that the steady decline in the overall organizational budget. Our home visiting investment remained relatively stable until 2025, 2026, when our organizational budget was at about $80 million, and the home visiting investment declined to about $26.5 million. And, you know, this really accounted for fewer hospitals, mutual agreement adjustments, shifts between the funding sources, and in alignment with our long-term financial plan. On the left bottom corner, you'll see that the total home visiting expenditures since 2013 are slightly above $400 million, and you see the change in hospitals from Welcome Baby on the bottom 2 rows and Select Home Visiting at the bottom of the slide. Now, for this slide, which we saw at the last board meeting, you can see that in 2009, our organizational budget was about $169 million and 132,000 births in LA County. In 2023, our organizational budget was at almost $87 million with 74,000 births. At this time, our home visiting investments are approximately 35% of our overall budget for this current year. And now, onto the Building Brighter Futures Equity Index, which we mentioned but didn't bring to the last meeting. I want to remind us that it's an internal tool that we are using to identify, as JR and President CEO brought up earlier, to highlight racial poverty and regional disparities by both measuring structural inequities in conditions of well-being, the 9 indicators in our strategic plan objectives, and also highlighting areas of high need, specifically the areas with high need populations of children 0 to 5. So we map the populations building from the last slide. And the orange boundaries that you see on the slide is where our Best Start communities are. And, you know, you'll see that our Welcome Baby and Select Home Visiting investments have been focused in the Best Start geographies, and they remain largely identified as high need, but we do see some shift in the areas of highest need away from the boundaries that were selected in 2010, which is why it's so important for us to continuously look at the data. The populations have shifted. Children 0 to 5 are declining, as you saw in the last slide, and also as the numbers are declining in terms of the share of the overall population. And you see some of this in high need areas like the Northeast Valley, Metro LA, and I want to really emphasize that it's not just about population shift, but that it raises the question about affordability of raising children in LA County. You might remember when Chris Ringwald, Senior Director of Research and Data Analysis from Catalyst California, came to share the overview on the Equity Index, and he raised that we're almost seeing 2 LAs in some of the areas where we are seeing the growth in births are maybe more affluent areas like the West Side, but in high need areas, families are feeling pinched. In other words, like they are struggling to support their children, and we're seeing that in the numbers. But those areas of high need where you see like the dark purple, they're still high or highest need areas. They just have fewer children because of the stress of raising children. And so for us, that's why it's so important to think about the results-based accountability framework, where we are talking about our strategies as First 5 LA, because the work that we do on policy advocacy, systems change, and partnering with communities in high-need areas can make all the difference, right, for children in highest need areas. There's 4, I just, want to reiterate that we are committed to using this tool to target our investments, and we have been working with the Department of Public Health and with Catalyst California to look at birthing hospitals, right? So where births are taking place, but also thinking about what high need families need when they are expecting and right after birth. And so that and we're going to hear a little later from Commissioner Priya Batra, who will share high level what the Department of Public Health is seeing for those families. And we want to also, get more input from our stakeholders and partners. So with that, I'll turn it over to Diana. And after Diana and Dr. Melissa Franklin do their parts, we will have time for questions from you on this section.
Thank you, Aurea. Good afternoon, Commissioners. So as part of understanding the root causes and what influences outcomes under the RBA model, it's important to have an understanding of the 3 models funded by First 5 LA and what they track and measure. So, and again, all of you requested an interest in diving in deeper. And so Dr. Franklin and myself are going to be doing a deeper dive into the 3 funded programs by First 5 LA. So as you can see here on the slide, we have Welcome Baby, which is an evidence-based short-term program. and Select Home Visitation, which is our initiative name, which includes Healthy Families America or Parents as Teachers, which are two evidence-based models, also funded by DPH and other administered funding by DPH. So First 5 LA also funds two key infrastructure elements that support countywide home visiting efforts. This includes Los Angeles Best Babies Network, or LABBN, which serves as an oversight entity, which I'll describe more in the following slide, and the Stronger Families Database, which is a platform that collects program participation and outcome data across multiple models and funding streams in the county. So together, these investments provide a platform with a backbone infrastructure that has helped home visiting function as a system in the county. Sorry. So here you can see LABBN, which has served again as the oversight entity since the expansion of home visiting for First 5 LA since 2013. They provide a range of support across models and funding streams. So they provide technical assistance and model fidelity, and this includes continuous quality improvement efforts, addressing site-specific needs, and being the local experts in all three models. So as an example, LABBN staff have attended model and curriculum trainings from the HFA national PAT offices, and they also serve as they oversee annual fidelity review meetings with the Welcome Baby site. So they serve as easily accessible and informed partners at the local level. For their workforce, they do provide a unique cohort training twice a year, consists of over 150 hours for new home visitors, helping to ensure a highly qualified and prepared workforce to work with families prenatally and postpartum. The training includes not only knowledge content, but also skills training, such as conducting assessments for maternal mental health, depression, and developmental delays. They also oversee the Stronger Families Database, monitoring for performance and development of data and data reports. They support communication efforts, including outreach materials, awareness building, and branding across the network. And finally, they do also host the LA County Perinatal and Early Childhood Home Visitation Consortium, which is always a mouthful, by providing workforce development, technical assistance, and data support. We also call it the Home Visiting Consortium. So with that, I'm going to share an overview of the Welcome Baby model, and following myself and Dr. Franklin, we'll talk about HFA and PAT. So we'll be highlighting some specific program elements across the three models. First, program goals. So Welcome Baby's primary goals are to maximize the health, safety, and security of the baby and parent-child relationship, and to facilitate access to needed supports and services. So as you heard in May, you'll hear an overview from Dr. Gonzalez later in the presentation. This does include a range of activities and outcomes, from supporting connections to postpartum well visits, immunizations, hands-on breastfeeding and nutrition infant support, conducting screenings, and navigation support to connect to needed services. As in all three models, the Welcome Baby curriculum includes a targeted focus on the quality of the parent-child relationship, which forms the foundation of the child's lifelong development, as we all know. For the Welcome Baby target population are the families delivering at the participating Welcome Baby hospitals, which again, as a reminder, were selected based on the percentage of the Best Start births occurring there. An important part of this does include the hospital visit as a central element of the program, which allows for a significant touch point for pregnant families, given that 98% of all births in LA County continue to occur in hospitals. And this is also where the triage occurs, where there is a needs assessment that identifies the family's needs and helps match them to the appropriate level of postpartum support. The program capacity for this fiscal year is currently 9 sites with up to 11,500 families a year. And you can see for program investment per child, primary program cost is personnel. Other costs range from supplies and office space and mileage and training. And of course, they do range across the sites, given some hospitals are larger, some are smaller, some have unique needs, such as Lancaster Palmdale will require more mileage and time for staff. So you can see here that the range for Welcome Babies anywhere between 1,600 to 2,000 per family, with an average of 1,100. And for enrollment eligibility, you see the universal component is delivering at the Welcome Baby Hospital, and there are no other specific eligibility requirements such as income or need. The program dosage, again, is dependent on when a family enrolls, whether it's prenatal or at the hospital visit, and whether they reside in a Best Start community. And finally, the program touchpoints has 3 up to 9 touchpoints. 3 prenatal, 1 at the hospital, and up to 5 postpartum. You can see on the slide there on the right the visits, and the program ends at the child's 9th month. And you will see enrollment and retention data in Dr. Gonzalez's section. The program does have a number of required positions, including leadership positions, a program manager, a clinical supervisor. It has a hospital liaison, which carries out the hospital enrollments, an RN, home visitors, outreach staff, and a data manager. And finally, in terms of how many families do staff see, given it's a short-term length of the program, they often have a higher caseload than HFA and PAT by design, so they can conduct 26 to 32 home visits per month. And with that, I will pass it on to Dr. Franklin to cover HFA and PAT.
Thank you so much. Good afternoon. I'll just scoot up. Before I get into the details of our shared models, it's important to note that I'll be sharing about HFA and PAT, which is shared models between First 5LA and DPH in terms of our investments, but I'll be sharing it from DPH's standpoint in terms of eligibility criteria, which our funding sources tend to influence that as well, so I wanted to share that. It's also important to share that we do not implement HFA and PAT, and then NFP is our other evidence-based home visiting model as programs in and of themselves. Rather, they are investments to achieve program goals in alignment with our requirements as an MCH Title V entity, as well as our funding partners, who primarily are DPSS, who funds our CalWORKs home visiting, and the California Department of Public Health, who funds our California home visiting program. Both of these partners require evidence-based home visiting and place an emphasis on serving populations who experience the greatest barriers to thriving and opportunity. They also include a host of wraparound supports and connections. For example, CalWORKs home visiting clients are able to receive $1,000 in material goods support, doula support, Medi-Cal enrollment, insurance, and care navigation support, and we'll soon be building a fatherhood engagement component, drawing upon our AIM fatherhood initiative. With that, I'll just go into each of the models. Healthy Families America. The goal for Healthy Families America is to promote optimal child health and development, strengthening, nurturing parent-child relationships, not dissimilar to Welcome Baby or Parents as Teachers. Enhance parental capacity, prevent child abuse and neglect from pregnancy, early infancy, through early childhood. Target population are pregnant and parenting families with children from prenatal period up to age 5 who are at increased risk for maltreatment or other adverse childhood experiences. You'll see in terms of target population, we've delineated it by our primary funding sources for our evidence-based home visiting programs. CalWORKs home visiting program, eligibility is, or target population is pregnant CalWORKs participants or parents of and guardians of children under 36 months. California home visiting program, MCV, overburdened families with ACEs-related risk factors, and we have 2 sites for that. That's internally delivered nurse-family partnership, and LUSD, who also provides nurse-family partnership as a model. So just as a note, and then Healthy Families America. And then FFPS Title 4E, these are candidates for foster care entry prevention, and that's through our partnership with DCFS. Program capacity, it's a scalable model. Site capacity is based on staff, full-time employees, typical caseloads up to 20 families per family support specialist, a minimum of 3 years of services per family. Overall, 483 to 918. For CalWORKs home visiting program, 395 to 790. CHVP and MCV, the letters, 48. And DCFS is FFPS, EBHV, 40 to 80, but I explained those previously. So if I need to go back over any acronyms, I'm happy to. Primary cost drivers for us are personnel, including family support specialists, supervisors, managers, plus national model accreditation, which is required, training and data infrastructure. Funding is structured to support a minimum of 3-year service period per family, plus any wraparound supports that we may embed in the program. Continuing with Healthy Families America in terms of enrollment eligibility, again, overburdened, low-income, pregnant, newly parenting families at risk for adverse childhood experiences or maltreatment. through risk screens, often aligned with CHVP or CalWORKs home visiting program. Insofar as CalWORKs eligibility includes pregnant or caretaker relatives of children under 3, they must be CalWORKs recipients. AB 607 expanded eligibility to under 36 months, thankfully, and families may stay for at least 24 months and continue short-term if CalWORKs ends. And thank you for advancing this slide. CHVPs and McVees eligibility are high-need families with ACEs-related risks, and then FFPS, evidence-based home visiting, children at imminent risk of foster care entry. Parents and caregivers can also receive services. Touch points and age of the child services typically begin prenatally or shortly after birth and can extend to age 3 years old, and in some implementation through age 5. Visit frequency tapers over time based on families' needs, and sites are expected to offer a minimum of 3 years of service, and we plan as such. Though some funding streams, including CalWORKs, may cap participation at 36 months, and the last time I was here, I talked about the complex network of funder eligibility, model eligibility, and also just requirements within our DPH or within our department. Core roles include family support specialists, which I mentioned earlier, and then supervisors and managers. Home visitors complete intensive training and receive reflective supervision. LA County HFA sites require a minimum of a bachelor's degree for the family support specialist role. And then in terms of caseload requirements, family support specialists serve up to 20 families at a time, with lower caseloads during early years for high acuity families. These are the touch points for Healthy Families America: birth to 3 months with intensive support, weekly home visits to support new families and newborn health, 3 to 6 months frequent visits and assessments to monitor child development and family well-being, similar assessments to what has been mentioned for Welcome Baby, 6 months to 3 years with tapering visits based on family progress and ongoing needs, and then up to age 5 in some implementations, continuing support to promote school readiness and healthy family outcomes. And then there is a child welfare protocol exception allowing intake up to 24 months in specific cases, which I mentioned earlier. Parents as Teachers, or PAT, program overview. Program goals are to increase parent knowledge of early childhood development, improve positive parenting practices, promote early detection of developmental delays, improve family health and economic well-being, prevent child abuse, and enhance school readiness. The focus population are pregnant and parenting families with children from prenatal through kindergarten entry, with local programs often prioritizing low-income and higher-stress families. All age-eligible children in the home are expected to be included. Again, as a note, in terms of eligibility, our funders also drive that as well. So insofar as CalWORKs home visiting program, as mentioned previously, pregnant CalWORKs participants are parents, caregivers of children under 36 months, and it's similar for California Home Visiting Program. And FFPS Title IV-E, in terms of parents as teachers, those candidates are, again, for foster care entry prevention, and their parents, kin-givers, as well as pregnant or parenting foster youth. Program capacity overall, 1,000 to 1,440. CalWORKs home visiting program, 525 to 700. California Home Visiting, that was CalWORKs. California Home Visiting Program, 495 to 660. And DCFS, our favorite FFPS, EBHV, 60 to 80 family slots, as we call it. Program investment per child reflects costs for educators, training, developmental tools per family costs, and varies by visit dosage, but also by who the funder is. Again, with programs like CalWORKs Home Visiting Program and CHVP, we have other wraparound supports that we provide with the funding in addition to home visiting. Enrollment eligibility, it is similar to what I shared before for Healthy Families America. I'm sorry, and thank you again. Program touch points and age of the child. Home visits start during pregnancy through kindergarten with at least a two-year engagement. Minimum dosage are 12 visits per year for families with fewer stressors, and 24 or more for families with more stressors, frequency tailored across infancy, toddlerhood, and preschool years. It's important for me to note that as a DPH and MCH division within DPH, we do focus on families most removed from opportunity with the greatest barriers, with a lot going on in their lives and their contexts. Type of staffing positions, parent, educator, and supervisor. And caseload requirements, full-time home visitors average about 18 families, with caseload adjustments based on required visit dosage. Needed screenings and group connections are also available. And this is a summary of the touch points. I provided highlights on the previous slide, but you can see them here in terms of prenatal, infant, toddler, preschool, and kindergarten entry, the 4 model components, which includes personal visits, group connections, and child and caregiver screenings, and a resource network. All of our PAT providers are linkages, they're strong community partners, trusted entities within each of their respective communities, and provide a host of other wraparound services. In terms of dosage guidance, again, I mentioned parents with, depending on what's happening in the lives of families, really determines the dosage for parents as teachers. And with that, we go to questions regarding the tour of some of the home visiting programs in LA County, namely Welcome Baby and our shared investments in Parents as Teachers and Healthy Families America.
Thank you so much for the overview of all 3 of those programs. And just one housekeeping note, we'll go through some questions. This is an opportunity for commissioners to ask clarifying questions. We're going to keep it to just clarifying questions from what was presented. We'll take a break, and then we'll go to the next part of the presentation, which I know is the best baby net. Okay. All right, commissioners, are there questions? Yes, Commissioner Requesby.
I'm not sure how clarifying this question is, but it would be clarifying for me. I didn't hear any discussion about if we are expanding or continuing Welcome Baby randomized control trial. I know that has been very challenging to do, but I hope that one of the things we would be considering is having the evidence base to be able to qualify, for FFPS. Both of the other models, obviously the select home visiting models do qualify. Just maybe it comes at a different point of the presentation, but I think it's a really important question.
Yeah, I'll just add, for historical context for everyone, a reminder that we did have the RCT planned, and we were ready to launch enrollment when COVID came. So at that time, we did do a pivot to a study of virtual visits. And given that we're developing the long-term plan and what that will look like, we put a pause in that conversation so we can better understand what the options are, understanding that it can take anywhere from 3 to 5 years to complete a randomized clinical trial and then get incorporated into evidence base with the state. So, yeah.
Any other questions? Commissioner?
I have a few.
Okay.
I was taking a lot of notes, so thank you for the presentation. And I do appreciate the thorough program overview. This is helpful for me being newer to the commission and not having a lot of experience with this program. So my first question is, when was the last time, this is an evidence-based program, when was the last time that an independent researcher evaluated the program? It was created years ago. How have we looked at the evolution of this program in the recent years to make modifications, especially now in light of the reduction in funding? So that's my first question.
Are you asking specific to one model or?
I guess for all 3, yeah.
Well, I'll start with Welcome Baby and we can tag on the other. For Welcome Baby, we did have an initial evaluation done of the pilot site back in 2010 to 2015. That one followed families until the child was 18 months old and did find significant findings of positive effect from participating in the Welcome Baby program model. We've done a number of other evaluations in terms of the Bridges assessment, which is the triage tool at the hospital, as well as an implementation study, and then a study around virtual. So there's been positive findings on that and made some adjustments to the model throughout the years. For HFA and PAT, those are national evidence-based, so they've had multiple RCTs done in the past 20 plus years. So I can't tell you off the top of my head when the last one was, but They have been studied in multiple diverse communities across the United States and continue to be found as being evidence-based, indicating that they do reach the outcomes as intended. You want to add anything?
Oh, no, you're correct. It's done at the national level. It's done repeatedly. I can't remember when the last has been done.
I can add, so I was going to speak on that later a little, like, do you want me to, can I share a little bit now, or should I?
If you want to give a little bit now.
Sure, yeah, and so, like, that's a great question. So HFA and PAT are known as evidence-based because there's, like, in terms of the outcomes of interest, like, that they're trying to move, key ones are child welfare system involvement, so abuse and neglect. And so it's actually, like, high-quality evidence for, like, decades supporting that these two models, and then nurse-family partnership as the third actually impact those, as well as like economic stability for families measured by like employment, use of benefits, and housing stability. And so I can like share with you or with someone, Linda, there's like a list of references.
With us, we could circulate it with the whole. Yep.
So there's like references, like some of the, because I was going to share on this later. So for example, HFA, like 27% fewer families experiencing homelessness, 48% fewer infants born at low birth weight. PAT, 50% fewer cases of suspected abuse and neglect. So kind of like hard outcomes, child abuse, neglect. For NFP, nurse family partnership, 82% increase in months employed for parent and caregiver. So like there's robust data like done not just by the programs, but by like third party like researchers. And then those two models are recommended by like the Community Preventive Services Task Force. That was in 2005. They recommended those like as kind of like strong evidence support to prevent abuse and neglect specifically. So I can share like references after this, but like those, that's where like the evidence-based like label comes from for those HFA and PAT.
Thank you, that's great. That answers my second question. I was curious because I do recognize the high volume of people that are being touched by this program, and I was curious about the outcomes that are associated with the engagement that is very robust. I was looking at the description, and so I appreciate that. I was going to ask about that, but that answers my question. And I guess my last question is related to what gaps have we identified that we have not been able to respond to, and what referrals? So I know that the program does not support any direct assistance, cash assistance, or any direct assistance to the family, which is fine, but I do know that oftentimes families have a variety of different needs, and so how robust is the referral process that is built into the program, and what connections are we making to other referral systems to help if a family is facing eviction, if a family is in need of employment, if a family is in need of other resources that the program doesn't offer, how robust is that referral mechanism? And then I guess the follow-up to that is, what gaps do we still have in the program that we're trying to potentially identify and solve for? Again, especially as we move into a different funding scenario where we may have an opportunity to look at that.
I'll start. I would say for Welcome Baby or for eCross, I think one of the findings that we've had, and Charlene, Dr. Gonzalian will share some of that data a little bit later as well in terms of what's being reached, is there is a lot of referrals that are provided, and navigation is always the challenge, oftentimes related to the systems themselves, either in terms of access, transport, affordability, eligibility. So I think that is definitely a gap across different areas where we see a high need, such as housing and food insecurity, and like the challenge of navigating. And I think the power of home visiting is that they're able to have consistent navigation support across the models to connect them. But that is definitely a challenge and an ongoing gap. And how do we use this data to work with those systems to help inform and support and enhance some of those connection processes?
The only thing, well, two things I would add. One is, and Dr. Gonzalez reminded me that our sites go through a 3-year accreditation on the national models, because that's required in order to ensure that they are able to implement HFA and PAT and NFP to fidelity. So that's really important. And it's similar for HFA and PAT sites. The beauty of the referral process is it's happening among organizations that are embedded in community. Same barriers or things that we run into that are challenges: housing, which is less about referrals and more about shortage, and the just a predominance of housing insecurity among all of our programs is across the board. In MCH, I would say between 12 and 25% participants are not stably housed. So that's a challenge, but I would have to give it to the sites in terms of them leveraging their relationships in community, making it happen for families. Areas that have been gaps that we're working to fill, doula access. So looking at ways to braid our doula services with home visiting services so that that can take place, and vice versa, doula clients being aware of and able to enroll in home visiting programs. Fatherhood engagement is something that's been lifted by both families and community, and finding ways that we are able to utilize the funding to provide support for fathers as well. And actually, I mentioned we're working to do that with our DPSS partners. And then the other piece is more streamlined referrals from our partners, which we're working on, like DCFS, right? It just is a strong partnership already. How can we make that seamless for families and easier to navigate in terms of the systems side of things?
Thank you.
And I'm with you on the cash and guaranteed income. We know that to be one of the evidence-based influencers on birth outcomes for families, and so thank you for uplifting that.
Yeah, well, my last comment is, I think what Ms. Carreaga just mentioned is like, how are we connecting to other systems here as First Five body? How are you using the data that we have already identified, where we do recognize that there's some gaps, and how are we sharing that information across multiple county systems, city systems, so that we can try to meet those needs? So I would be interested in that conversation to see how we can step in as a city to help support that. Thank you.
Commissioner Cortez.
Thank you again so much for the this deep dive, and for really going into just really great detail about all of the kind of intricacies of all of the programming. I really appreciate it. I had a question. I really wanted to uplift and thank you again for including the staffing information and requirements. I think I asked about that last time, because I was, again, always thinking about my students and how I can help them to understand those different pathways. And so I really appreciated that. And I wanted to know, and I don't remember if I asked this last time, so forgive me if it's repetitive. I wanted to know if you're working with any institutions of higher ed to recruit folks to work with you all, because I know it with the bachelor's degree, and with most of the requirements are for a bachelor's degree or above, but I think it might be really wonderful to connect those other spaces to, let them know. I was just talking to a student the other day who was really thriving in one of my classes and has no intention of going into child development. And I was like, I think this is really for you, and you don't have to be a classroom teacher. And she's like, really? And so a lot of our, the general population doesn't always know what other options they have. And I think this is a really great way that you can work with children and families, not necessarily the parent-teacher piece, but I do have students that are parents that would be really wonderful for this role when they're ready for that next step. So I was just thinking about that. So that was one question I had, and I didn't know if you wanted to respond or if you had thought about that.
We can share, not in a formal, standardized way. We know that it has happened, but not in any kind of formalized way.
Great. Yeah. Okay. Yeah. So that's a great, maybe possible next step to work with different communities. And again, I want to highlight the community colleges, because we're always looking for ways to boost our enrollment, and I think it's a really great way, kind of pathway again. We don't have a certificate for home visiting. I keep pushing for it, and so this kind of data and information really helps us, because they need to see the numbers, and that it would be a really great space. But we do have a space now for special needs and trauma-informed care, and so that I think is another route, but I'd love to see that on the books. But again, we have to show that there's a high demand. I wanted to just ask about, sort of piggybacking on Commissioner Marquez's question about evidence-based practice. I didn't hear this, but I wanted to just if I misheard, please forgive me. I wanted to just ask if there's a connection with the kindergarten or school readiness now, right? I know that there's a lot of reasons why this program works and why it's really beneficial for families, but has there been like a specific connection with the school districts that tie it back to these children that had this intervention are then ready for school because of all of the needs that were met from the family base?
I would say certainly for HFA and PAT, there is a strong evidence base that it does create that strong early foundational piece for learning that prepares them to be in schools and ready to learn. That's actually one of the direct goals of parents as teachers. And so they definitely support the readiness to be able to enter school, if you want to add.
Yeah. You definitely covered it, parents as teachers in particular, but I would say Healthy Families America as well, because of support with developmental milestones, identification of where there may be opportunities to provide a little extra support for families that feel like they're not reaching those milestones for their infants or children, and that being a part of readiness for kindergarten.
So again, I'm just wanted to kind of ask if there's like a possibility of other institutions of higher ed working with you all to help you collect that data, because I think that would be really, really strong supports for these programs continuing and other funders being able to kind of come in to that space, because it's really important. And I say this all the time to my students, and I'm sure you all hear this in other ways, but we care about kids when they start school, and we don't necessarily always show that we're really, caring about them before that. And so one way to really get other people to pay attention to it is to collect that data and to have those resources readily available, so we can say, we know this program works and we know that you should fund it because, right, these things. And you're absolutely right. I don't disagree. I know it is in my bones and my brain and my heart, but I want to make sure that we have that data readily available and that we can work to collect it so that it continues to push that forward. Thank you.
Thank you. Are there other questions from commissioners? No? So I do want to offer a clarifying question just for the sake of making sure that we're all on the same page as we go into the second portion of this conversation. That we're looking at 3 distinct programs, and Welcome Baby is a signature program of First 5 LA. And that is the program that this board has the most influence on. PAT and HFA serve very specific and critical roles and are models in their own right. And Welcome Baby is what we are sort of looking at right now to decide the future of it. And that is what we are being asked to do, especially in the second part of this conversation, correct? Mm-hmm. Okay. So go ahead, please.
I would say yes on Welcome Baby, but all 3 programs, because we are funding Select Home Visiting, the 2 programs as well. So thinking about there, in the last presentation, right, there were opportunities around thinking about the support for the Select Home Visiting program, and actually even for Welcome Baby. So yes, the answer is yes on Welcome Baby, but I would say that it's all 3. And I would say that in this last part of the discussion, like where the gaps are, like what are things that we need to be doing? What does that mean for Welcome Baby and the other 2?
And just so we know how to present questions, will it be helpful if we identify specifically when we ask questions which programs we're referring to, because they are distinct to HFA and PAT are evidence-based, Welcome Baby is evidence-informed, and serve populations in their own ways? Would that be helpful?
I appreciate you bringing that up, Vice Chair, because the piece around school readiness, because Welcome Baby is up to the first 9 months in terms of collection of data for school readiness, right? It's in the first year of life, where the other 2 go through 5 years, right, for parents as teachers, up to 5. And so, there's longer term data for those ones. So yes, I think identifying the programs and the distinction of evidence-based versus best practices informed.
Okay, thank you. And the reason I'm asking that is because I've learned so much about home visitation as a whole And I learned a lot about it prior to this from the community. And the community tends to tangle all three and just braid it together as home visitation. And sometimes they're so positively impacted by it, they don't even care the distinction or the name. They just know that they're being served in this way. But for the purpose of this conversation to be really productive, I think it's important for us to make those distinctions. So thank you for clarifying. Yes, Commissioner Blakely?
Yeah, thank you. I just had one clarifying question for the second half of the conversation. As we look at the, I know we go into First 5 LA impact across LA County and look at the demographics, will that, are the demographics representative of all three programs or more specific to one versus other? I just want to make sure, because I think last month we had said something about it doesn't fully represent the full impact, but I just want to clarify.
Well, we're presenting some additional data with Dr. Gonzalez's piece, and it does call out distinctions between the program models and who's being reached.
All right, thank you. Are there any other questions from the commissioners? We can take should we do a 10-minute break and come back at 3:30 or 11-minute break? We'll come back at 3:30. Thank you. our meeting. Thank you, everyone, for your questions before the break. And now I want to turn it over to Dr. Shirlene Ghazalian. Am I saying that correctly?
You're saying it correctly. Thank you so much.
Perfect. All right, thank you so much. The floor is yours.
I was just curious if you'd like to hear a joke to increase the energy
Yes.
in the room a little bit. All right, whether you laugh at me or with me, I don't mind, so either one works. All right, I used this one just a couple days ago during our home visiting summit that we hosted for HFA Patent Welcome Baby. We had over 450 participants. What do you call a fish that wears a bow tie? Sophisticated.
That's a good one. Thank you.
That was good, right? It was all right. It was okay. Okay.
I love that joke.
Okay.
Yeah.
I've got more if you need it later, but I'll
Anytime, you
jump
can
into my
always- yeah.
presentation
I'm
first,
always
and then
down for that
I'll. Okay. Wonderful. All right. Good afternoon, commissioners. Nice to see you all again. This is going to be a continuation from last month's conversation. Today, I'll be sharing an overview of the First 5 LA long-term investment and impact across Welcome Baby, Healthy Families America, and Parents as Teachers, including trends in engagement, referrals, outcomes, and family needs across LA County. Before we dive into the data, I want to begin in grounding us in the scale and reach of the work. Since July 2015 until June 1st, 2026, Welcome Baby alone has reached over 189,000 unique families across Los Angeles County. Welcome Baby had over 91,000 Best Start families and over 98,000 non-Best Start families who enrolled in these services. Healthy Families America has enrolled nearly 5,000 families, and Parents as Teachers has served more than 3,200 families. Just on the Welcome Baby side, these enrollments have resulted in over 400,000 home visits delivered directly within communities, including homes, hospitals, shelters, clinics, and neighborhoods where families live and raise their children. One of the most important things to understand about home visiting is that the relationship-based and prevention focus. Home visitors are often identifying challenges long before they escalate into crises. They're seeing the realities families are facing in real time: housing instability, adverse childhood experiences for the parents, trauma, food insecurity, maternal depression, anxiety, developmental concerns, and social isolations, and helping families navigate support systems before these issues become emergencies. Another important point for the role of Welcome Baby is that it plays as an entry point into the broader home visiting continuum. So specifically for First 5 LA, approximately 80% of referrals into the First 5 LA funded home HFA and PAP programs come directly from Welcome Baby. This is not siloed, it is coordinated, connected, and community rooted. A little bit earlier, we were asked about demographics, so I'm going to talk about race and ethnicity and outcomes specifically. This slide looks at the racial and ethnic composition of families served over time. You'll see both a 10-year overview, again, July 1st to 2015 until June 1st, 2026, and a 6-year overview, July 1st, 2020 through June 1st, 2026. The reason I chose these particular timelines was actually COVID. I was curious to see if there was a difference between that time. What we see is a remarkable consistency in populations being reached. Hispanic and Latino families continue to represent most participants, roughly 3 out of every 4 families served across both time periods. At the same time, we are seeing slowly increasing diversity among participating families, particularly among Asian families and families identifying as multiracial. We also observed a slight decline in participation among Black and African American families. While the change is modest, it is something we continue to monitor carefully given the persistent maternal and infant health disparities experienced by Black families across Los Angeles County. Overall, the data suggests that the network has remained deeply connected to the communities it was originally designed to serve, while also reflecting the growing diversity of Los Angeles County. Next, we'll be looking at income trends across the network. Similar timeline as the slide before. One of the most significant findings is the sharp increase in families categorized as either do not know or decline to answer regarding income. Combined, these categories increased from roughly 71% to more than 80% over time. It is important to distinguish between these two categories. Decline to answer may reflect discomfort sharing financial information, privacy concerns, fear related to benefits eligibility, immigration concerns, or distrust of the system in general. Do not know often reflects a different reality, particularly in households experiencing economic instability, informal employment, fluctuating income, shared housing arrangements, or dependence on multiple family members contributing financially. In many cases, families genuinely may not know the household's annual income. I want to note that this information is a self-report and is not a requirement to being eligible for any one of these three models. We also saw a decrease across nearly all lower income brackets. Importantly, this does not necessarily mean fewer low-income families are being served. Instead, it means more likely reflects increasing challenges and stigma obtaining accurate financial information during visits, particularly following COVID and ongoing concerns of our political climate in Los Angeles. Even with the increase in unknown data among families who did report income, the majority continue to fall within very low income categories, reinforcing the significant economic vulnerability within the population we serve. As you wish. Next. Engagement and enrollment. This slide highlights enrollment trends across Welcome Baby over the last decade. So again, July 1st, 2015, up until June 1st, 2026. At its peak, the network enrolled more than 14,000 unique families annually. This does not include families who were referred into the HFA and PAP programs at bedside. While we have seen declines in more recent years, it is important to contextualize these numbers. The Welcome Baby Network originally operated across 14 birthing hospitals, and in the current fiscal year in the network we're operating with 9. Despite the reduction in hospital infrastructure, the network continues to engage thousands of families every year. These numbers also reflect broader system realities: staffing shortages, hospital transitions, COVID-related impacts, and funding shifts across the maternal and early childhood landscape. What remains constant is the demand for support. Families continue to seek connection, guidance, and trusted relationship during pregnancy and early parenthood. Regarding family participation and retention, this slide focuses on longer-term engagement. Since 2015, more than 5,400 HFA and PAP families who received at least one home visit have closed services, and we continue to see varying levels of participation length across the program. Additionally, HFA and PAT have collectively graduated more than 1,500 families, which means that we did serve them successfully between 3 to 5 years until they aged out of the program. For Welcome Baby, we also see a strong graduation outcome amongst Best Start families, with approximately 68% successfully graduating from the program. This matters because retention in home visiting is often one of the strongest indicators of relationship strength and family trust. Families remain engaged when they feel supported, respected, culturally affirmed, and when services continue meeting evolving family needs. Regards to referrals and connections, this slide is specifically for Welcome Baby. My next slide will touch upon HFA and PAT. One of the clearest indicators of family need across the network is referral activity. Since July 2015, Welcome Baby programs have made over 231,000 referrals. Basic needs referral dominate both referral volume and completion rates. This includes food, diapers, housing assistance, utilities, transportation, and emergency supports. Healthcare and parent education also remain major ongoing service needs. What is especially important is to highlight is the continued demand for mental health and behavioral health services. While referral volumes remains high, completion rates are comparatively lower. That gap reflects broader systematic barriers families face, such as provider shortages, insurance limitations, stigma, waitlist, transportation barriers, immigration status, and culturally responsive access challenges. Home visitors are often serving as navigators and emotional anchors while families attempt to access fragmented systems of care. What's not captured in these numbers is the life skills building. Teach a man to fish concept, how to advocate, recognize that you have needs, how do you navigate a resource system, making an appointment, making a phone call, required paperwork I need to make this appointment, which ultimately increases health literacy and the family's efficacy in being able to do these things on their own when the program closes. As related to HFA and PAT, we see very similar patterns within these two models as well. Again, basic needs overwhelmingly drive referral activity. At the same time, we see strong engagement around parent education and family recreation or enrichment activities, highlighting that families are not only seeking crisis support, but also opportunities for connection, development, and healthy parent and child engagement. Mental and behavioral health needs again remain consistently high. This report reinforces that home visiting is functioning not simply as an educational intervention, but as an integrated family support and prevention infrastructure. Looking at just a few select birth outcomes. This slide presents shared birth outcome indicators across the 3 home visiting models. Before discussing the data, I do want to provide important context though. None of the 3 models as currently implemented under First 5LA have high levels of prenatal enrollment. Additionally, Welcome Baby specifically was not originally designed as a prenatal birth outcomes intervention model. However, these indicators continue to be tracked across all 3 models because they remain critically important maternal and infant health measures. What we see overall are relatively stable outcomes across time, including low birth weight, preterm birth, postpartum visit attendance, and childhood immunization rates. Particularly encouraging are the high rates of postpartum visits and immunization completion across the programs, which are higher than the LA County and state of California averages. These findings suggest that while home visiting may not directly drive all medical outcomes independently, it plays an important role in care coordination, family education, healthcare engagement, and connection to services. Then child and health safety outcomes. This slide highlights these particular outcomes. Across all models, safe sleep education completion average approximately 98%, which is extremely strong and important given the role of safe sleep practices play in infant mortality prevention. We also see consistently high well-child visit rates across the programs. These are important indicators because they reflect ongoing engagement with pediatric care systems, preventative health care, developmental monitoring, and family health education. And in this particular slide, I know it's heavy, and I believe you all have a larger copy in your packets. I just want to note that this final slide illustrates the strong alignment between First 5LA's strategic objectives and the work already occurring across Welcome Baby, Healthy Families America, and Parents as Teachers. Across all 3 models, programs are already measuring outcomes related to maternal mental health, developmental screenings, economic stability, housing insecurity, early education, cultural responsiveness, and family well-being. Many of these measures are tracked through standardized tools such as the PHQ-9, GAD-7, ASQ-3, and SE2, referral tracking systems, family goal attainment measures, and client engagement indicators. The language may differ somewhat from the strategic plan framework, but the alignment is already deeply embedded in the practice. Ultimately, this work represents far more than the individual visits. It represents an integrated county-wide prevention system supporting families during some of the most critical periods of child development. And perhaps most importantly, it represents the dedication of the home visitors themselves, professionals who continue showing up every day for families, often during moments of significant stress, uncertainty, and vulnerability. Behind every number in this presentation is a relationship, a family story, and a ripple effect that extends far beyond that single visit. Thank you. I'll pass it on to Dr. Batra.
Yeah. Before you begin, are there any questions for that last portion?
Yeah,
And I'll go to you, Dr. Batra.
Yeah, great presentation, and really impressive to see the scale of the Welcome Baby investment to date. It's really big numbers, so great to see that. Just a question on the income. Do we collect or do we ask about payer, like Medi-Cal versus other? Because that would be a great surrogate, and I'm always hesitant to make assumptions about why people report or don't report. So do you have proportion of Medi-Cal enrollees in Welcome Baby?
We do. It's roughly around 77%.
Okay, that's helpful. And then just in terms of some of
And I'm sorry, it's not very different in HFA or PADI either. Yeah. It's around the same number.
Great. And then for Welcome Baby, just I think you qualified the birth outcome data appropriately because the preterm birth rate in Welcome Baby is half of the state or county or a third of what we see in the county. So it seems that's tough to interpret, and you did point out it's not an antenatal intervention. But then how are you collecting the preterm birth and information, and then also immunizations, because Welcome Baby follows for 9 months, is it immunizations completed to that point, or how are you getting that information?
Yeah, so specifically regarding preterm birth and low birth rate, straight from the client's chart. So at bedside, when the hospital liaison is enrolling a client, they have access to the client's chart. Aside from a conversation directly with the parent, they are able to gather that information. They collect information regarding if their gravity parity, if the baby's in the NICU, weight, gestation, all sorts of things like that. They also gather information regarding the number of prenatal visits that were completed before giving birth as well. So all of those, what I'm going to consider a little bit more validated data, given that it's coming straight out of the EMR in that sense. Immunization is self-report. So I think that one is really important to point out. To your point, welcome baby, yes, the last point of data collection is at 9-month closing. Okay. And then for HFA and PAT, the last point is either at 3 or 5 years, depending on when that family closes out.
Thank you.
Sure.
Commissioner Blakely?
Thank you. I believe we talked about this last month, but I just wanted to make sure I understood as we brought it back this month. If we can explain the large, I think if I did the napkin math right, 68% gap between Latino and Hispanic versus Black and African American, and I know you had mentioned Black infant mortality, and I think it's 3 times, Black mothers have 3 times the rate of that happening versus their white counterparts. And so I'm just wondering, is it just an outreach thing? Is it needing to have more culturally affirming space? I just really want to kind of deepen that, and then I have one more question after that. Yeah.
I think it's fair to say that our engagement with Black and African American families is not necessarily low, it's the enrollment. And I want to make that difference. And anecdotally speaking, I think part of it is trust and the timing of the enrollment or the request for enrollment, right? We've got eligibility requirements of when that family needs to say yes by. And we're fairly strict. I've got my partners sitting in the back that are really good about asking for exceptions. So we'll give them, but the family needs to come back and ask for them, right? So I think that's one of the challenges. It's not necessarily that we're not seeing them in the community. We are not seeing high rates of a yes. And that's something that I think has been on the forefront of our minds for quite some time. Even through the consortium, we have the African American Home Visiting Engagement Work Group. We've got hiring guides. We've got practices. We've done family focus groups. When it works, it works. But we're still trying to figure out how do we get a family to say yes. And that's, of course, across the board, but in particular within this group as well.
Mm-hmm. Okay, thank you. I mean, because I think that, to your point, I'm glad you clarified that, but it's wondering how do we unpack that, why they are not saying yes, and why are they choosing to be untrusting of the system? And is there opportunities for other partners to come around to be a vehicle to lead them to that door because of the really great resources that are there? And then I just wanted to, this is a clarifying question, it'll be really quick. Referrals made and completed, how are you defining completed within these metrics?
So at the time of closure, referral completed could mean that they actually successfully, not only successfully engaged, but received, and where they're at is we're all set, we're good. We've been able to successfully check mark and say this is no longer a concern or a need for that family. For some of this also, it represents, if the program is closing out, that they are engaged actively and on a successful path to continuing to a successful closeout within the referral system as well.
Okay, thank you. And then just this last comment, and I'm done. You had mentioned, and it's more just emphasizing a point you mentioned, if I heard it correctly, in terms of the enrollment of the programs, in terms of the decline, especially looking at the most recent year that you have on here, and the concerns around it in respect to hospital capacity is a real big concern for me, because I'm just thinking about more broadly as we even think about some of these other wraparound supports we can utilize to keep these programs to do that intentional work. There's something that's out of all of our control, and just what that means for the long-term impact for this critical work. I just wanted to more emphasize it, not a question or anything, but I just heard you say that. I wanted to call it out. That was all. Thank you.
Thank you. Any other questions from commissioners?
I just had a quick comment, possible suggestion, just kind of piggybacking on your ideas about what we're missing or why the gaps. So we had all those families that were recently, I believe, giving public comment or that have had services before. And I think that word of mouth is really strong. And then having some sort of, I don't know, I don't want to say community fair, but I'm sorry, my words are slipping away at 3:50 in the afternoon. My apologies. But some sort of kind of gathering of sharing ideas, I think, would really be helpful, because I think that they're going to trust community members that are going to be, that have already used the services, and that hesitation may really dwindle from, when it's, not the person with the badge and the suit, but the person that lives next door, down the street, or whose friend of a friend used it and really benefited, especially with, if there were specific issues like, I don't know, recovering from, cesarean section or postpartum depression, all those things, or having multiple children that you have to, try to take care of in addition, right? I think those are the ways that we kind of help to fill those gaps. So, thank you.
Any other questions? I do actually have a question on the slide that has the birth outcomes for low birth weight and for preterm birth. You mentioned that the data is collected at bedside. Do you separate based on a birthing person who was enrolled in the program before that point? So if they're in Welcome Baby for 3 months prior to giving birth and they had a preterm birth or low birth weight, is that data separated from someone who enrolled at bedside and had low birth weight?
So you're essentially asking if we can cut the data for families who are enrolled prenatally versus postpartum?
Right.
We absolutely can.
Yeah.
But this particular data is not cut that way.
Okay, because I would be interested in seeing the impact on someone who was enrolled in the program before they gave birth, to see how that would impact their preterm birth or low birth weight, if they would have better outcomes, instead of having all of that data collected together, because there might be a significant difference between someone who was enrolled prior to giving birth. Okay, thank you. And then the other question, so it is on the slide that had the data disaggregated by race, and I wrote down 4 questions, like who is being reached, is that the goal, how have the strategies changed to reach the goal, and what can be done to be a better connector. And you mentioned that, so for Latino communities, the numbers are declining, but it's still more than proportionate to their population in society or in LA County. For Black families, it's proportionate to their population in LA County, but still much lower, given the high impact and threat to Black infant health and maternal mortality. And so my question is, when you make engagement and there's not enrollment, is there a follow-up question as to why they're choosing not to enroll?
There is, and there's even up to 3 additional check-ins with the family of trying to get them enrolled, especially if they're Best Start designated in a Best Start community. So just because a family says no, it doesn't mean it's necessarily, we're not engaging with them anymore. In fact, I'm actually remembering what Commissioner Cortez asked last time of, do you ask the family, I think it was, or maybe it was Commissioner Hager, about do you ask a family where you're at? So it's exactly using that particular thinking of, maybe when we engaged with the family, they were just in a different space where they couldn't make a decision. Can I check in with you in a couple weeks? Just giving them a call, sometimes even providing them a bag of diapers without enrollment is incredibly helpful, because when we've done focus groups with families, oftentimes, and particularly Black and African American families, the first thing that we hear is, I need to know if you're genuine and you're going to show up for me, right? It's consistency and follow up and follow through. What we hear often is, I don't need you to have every answer. I just want to know that you have the best interest in my family. And that's what gets people, gets them enrolled. So when we have our outreach specialists or our home visitors who make a few attempts, maybe it wasn't a good day, I want to check in, or I remember you mentioned that you were looking for XYZ for your older child, here's a resource, I just want to call and give it to you, but there's no enrollment necessary, there's nothing on the hook for it. We have seen really successful enrollments in that method.
I love that. Would you be able to share data on their answers for when they choose not to enroll?
I can, up until a certain point. In terms of when a family decides not to enroll, that is it's in bucket categories. And to be honest, most of the time they say we don't need it. So the majority of those that are closed out are because they specifically say, I don't feel like I need this program. The second one is we engaged, but then we try to re-engage and it's lost the follow-up.
Okay. When you ask, is it an open-ended question or are they given options? Like, do you not have the time? Do you not want to?
It's fairly open-ended, and then the staff are guided to ask open-ended reflective questions, and then based off of those responses, we've got protocols of how they bucket the answers into the database.
Okay, thank you for that. Because it's all speculation on my part, but just talking to a lot of families in the community and knowing that home visitation is tied to like reducing system involvement or reducing possibility of ACEs, a family that's feeling balanced and supported may see this as something that I don't even want to involve myself in, because if there's even the chance that I might be flagged by a county agency or an agent of the government, then I don't want to be involved, because that historical mistrust is there. And so it would be interesting to see if we could somehow harvest more feedback from the community when they say, I don't want to do this, and somehow, without prying, get to the root of that question. But I appreciate the efforts that you're making, so thank you.
Thank you.
All right, I'll turn it over to, Commissioner Blakely?
I'm wondering, with this demographic breakdown, is there tracking of who enrolled at a prenatal stage versus, at, I guess, bedside? And I'm even thinking about going back to our African American and Black demographics. I'm wondering if there is some built-up time in the prenatal era of that relationship building. Maybe that will lead to more trust, to recognizing why this program may be so beneficial for that specific group. Just throwing it out there, just because you had mentioned a comment regarding some other data points of birth outcomes. I'm wondering if that same type of understanding could be applied through this. But wondering, is it broken down in that way already, and is that something?
It can be. So essentially, anything that goes in the database, we can use it as a way to cut the data as you wish. So whether that's prenatal, postpartum, by race, by income, by Best Start community, any of that is quite possible. It's just understanding what exactly your, I'll put in a data way, what your research question is, and then us looking at the different variables we have available and cutting the data as that way. Yeah. I just want to make one note that just for perspective, it's probably about 23.5% of our families are actually enrolled prenatally. So that is correct. You can potentially enroll a family in Welcome Baby as early as 12 weeks, and then have 3 prenatal engagements up until 38, 39 weeks, and then the next one is the hospital space. So about 23.5, 24% of the families are seen prenatally, but the database is designed in a way where you outreach to way more than that. So they get a little flag next to their name. They're coded, so like if I'm a hospital liaison and I go into, I'm about to see a client or potential family that may enroll, I know that I saw them at a WIC event or a baby shower or something. They may have not engaged, but we told them we'll see you in the hospital. So that changes the pitch of how I'm approaching this. It's not necessarily I'm introducing the program for the first time. It's, hey, I remember seeing you, or you saw my colleague so-and-so at the WIC baby shower. I'm here just to kind of continue talking about it, answer some questions, and so on and so forth.
Thank you for that. Any other questions? Yes,
I do have a question. So it's a data question, and it's kind of a deep, like nerdy type question. So of the families that, for the data you have, of the families who initially said no thank you, but eventually enrolled, is there any follow-up that happens with them that said, what changed your mind?
What persuaded you to say yes the second time or the third time?
The baby showed up.
Baby showed up.
It got real. I say it as a joke, but very often, especially for first-time families, that is what seems to be the turning point, is prenatal. You're carrying the baby, not necessarily external of you, so things aren't, things are a little bit more calm. I don't know how calm, but calmer. And then the baby is here, and now you're postpartum, and you realize I need more help than what actually was happening. I will say, so that's very specific to Welcome Baby. I will also say what's really nice about our partners at HFA and PAT, quite frankly, regardless of its first 5 or DPH funded, because we have methods of getting families wherever they need to be. It's best fit, if you will, in that sense, regardless of geographic location as well. But the nice thing I will say around HFA and PAT is with HFA, you can enroll a family up until 90 days postpartum, so they're 3-month. On top of that, many of our HFA sites have it's an additional clause that families who are DCFS involved can actually be enrolled up until 2 years postpartum. So to the child's 24-month birthday. And then for PAT, you do have 2 years to enroll that child. So even when a family says no to us, let's say no at bedside, you still have a method of engaging and sending them to another program. And that's often what happens as well. Is, okay, you said no to Welcome Baby, that's okay, and then we get a call back a little bit later realizing you need more, and then you just kind of divert that referral to the right place.
I just wanted to say I appreciate your anecdotal information, because every story then hooks us up to a much broader perspective than just the idea, just the numbers. So thank you for that.
Appreciate that, thank you.
Yeah. All right, any other questions? I'll turn it over to Commissioner Bartram.
Thank you. So I gave a little preview of some of the evidence base. So I was asked to speak a little bit, just to back up, I think we're in the weeds, but the question for the board, the commissioners and partners is in this environment, what do we invest in as far as home visitation, right, if it looks like it has to change? And so I wanted to share a little bit about how at Public Health we have made our decisions around investing in home visitation, because we face sort of the same questions and the same limited resources, and we're serving the same community. So I'll be pretty quick, but just first, looking at it from a public health science lens, right? We start with well, what are the adverse outcomes for pregnant and parenting families that are our priorities, serving the entire county. And so those are infant mortality, maternal mortality, child welfare system involvement, and economic instability. I mentioned specifically with respect to employment and housing for our families. And I want to just note that these are pretty terminal, long-term outcomes. They're not easy to move, and they're very distinct from some of the process measures, so outcome measure versus process, right? So process measures that we also think are important and that we track. And so those are some things we've heard about today, recommended healthcare visits being completed, getting your screenings, experiencing toxic stress. Those are things that we measure and that we count on as proxies towards the goal, but we're looking at what can really move the outcome itself with limited resources. And so recognizing that these are the outcomes we want to move, we then look at who is disproportionately impacted by these adverse outcomes. And I think a lot of our commissioners and everyone here has really highlighted that today already. So of the 4 things I mentioned, they're disproportionately impacted, seen in populations who are Black or African American or American Indian, Alaska Native identifying in our county, who are low income, enrolled in Medi-Cal. So for example, we talk about the racial disparities in maternal mortality, which are quite stark, Black versus other, but then actually if you have Medi-Cal, you're more likely to die related to pregnancy. So that's another proxy. And then a lot of the geographic disparities that we saw actually in your equity index map with those same factors. So it's the same communities really recapitulate the impacts of racism, marginalization, economic no opportunity, right? And so these root causes, I'll just say are shared by many of my colleagues at Public Health in terms of the outcomes we're trying to impact. And so that's how we look at who we're trying to move these outcomes in. And then I just want to say that we then say, okay, well, what are evidence-based interventions to move these outcomes, recognizing that they're really hard to move? And then I already mentioned that evidence-based models of home visitation. So what we have today in that space are Healthy Families America, Parents as Teachers, and Nurse-Family Partnership. And those are what we look at in terms of evidence as effective. And so they also impact those intervening process measures that Welcome Baby and other programs affect, which is like promising, but we're looking like at the long-term picture. And then just to back up again, like home visitation is like one evidence-based, intervention we're pursuing. Others are like guaranteed basic income, which is, I think it's evidence-based, but it's really supported at this point. Like we're getting data. There was like a study in Michigan that showed birth outcomes improved. So that's very promising. Doula, again, on the maternal mortality piece, has some good evidence, and then also process measures are impacted. So I'll say home visitation is just one thing we're looking at. And so for first 5, like, it's probably going to be a suite of things, right? So I would hope that, like, if we, move on home visitation, there may be other things that we want to, explore that are evidence-based or evidence-supported. And that, we're not alone in using the evidence to support what we select, like as Dr. Franklin mentioned, CDPH, that's why they support these models. CalWORKS also recommends some of these models because they're the best thing we have right now. And then I already shared why they're evidence-based, and then I shared some of those references. Some are from the home visiting models, so with a grain of salt, but then also I provided some more independent evaluation information you can look at. But that's sort of how, from a public health program design perspective, we've moved in this direction. And then I'll also note that, I think other programs are learning from home visitation as a promising model. So there's enhanced care management, which is a CalAIM benefit. Birth equity is a population of focus they want us to serve. And we provide ECM. We're trying that out in our MCH division. And it actually crosswalks, it's funny, we're seeing our Nurse Family Partnership nurse visitors are more aggressive in outreach than ECM. They come to your house many times. So actually they're very, very, they crosswalk pretty closely. So just to say that I think these models, there's more and more appreciation even in the clinical care delivery system of this social or public health intervention. And then I'll just end by saying the other question we have to answer and First 5 has to answer is how do we do this intentionally, or what are we trying to, how are we trying to deploy these resources? And for public health, we're being targeted. So it's not a universal approach because we feel in a limited resource environment where we have clear disparities, we need to be focusing on communities that need them the most. Not to say we don't cover the whole county with our home visitation program, but we're trying to do outreach intentionally with partners, trusted messengers who can get us to the populations we need to be enrolling. These are really expensive programs. They are long, and they impact terminal outcomes because you enroll in pregnancy, and ideally you stick with it through toddlerhood. So it requires fidelity the way it is. It requires the type of workforce that can engage patients for a really long time. And so our sort of approach with home visitation is to put these intensive, expensive programs into marginalized communities. That's sort of how we're moving. And so we're going to continue kind of that approach. And that's what I wanted to share. So just as we think of, that's how public health is investing in these models. And so happy to share more information on that. I think you heard a little bit about it from Dr. Franklin as well. And it's one of other, a suite of other evidence-based programs I think that the county can leverage.
Thank you, Dr. Batra. Are there questions from other commissioners? Yes. And thank you for joining us.
I know. Thank you for inviting me. No, thank you very much. And I will say, though, sitting over there, now sitting over here, listening to you, listening to all of you, is there an easy way for someone just to understand, First 5 LA is investing in home visiting, and in, all these, Department of Public Health is investing. How are we making sure that whatever these two entities that have such similar cultures, I think, and goals, and hoping to impact a similar geographical area, how are we coordinating, or are we not? Is it just maybe done through Best Babies Network, or or some kind of common program that each is funding and training people to be part of?
There is so much coordination, Commissioner Whistler.
I'm sure
We-
there
we-
is.
We have
I
been
just- I
very
wasn't
coordinating
sure
very
anybody's
closely.
spoken.
The HFA and PAD sites are the same agencies that are being funded by both sides. And there's a common database that connects many of them. And there's quarterly meetings between staff from First 5LA and DPH. So there's many touch points where there is coordination across to connect families. And even when there's families that, can't get into one funding stream, can they get into another? And there's communication to really maximize all of the available slots. So there's, across the system, I think there's always been intense coordination.
Okay. And is that through I think of DCFS has, the hotline and everybody calls into one center. Is there like a center that hospitals are, or is it all being done by the hospital and then you're working through the hospitals, or?
I would say for Welcome Baby, it is being driven by, they have outreach staff that do go out to the clinics and maternity hospital tours to conduct for the prenatal piece and then the hospital enrollment. Our HFA and PAD sites do conduct their own outreach for prenatal postpartum for Best Start families, which is part of the challenge for low prenatal. But then on the DPH side, they have an extensive different ways of also recruiting families into the programs.
I think it's also important to note that we're all on the same data system. So the Stronger Families database
All right,
is.
so then you can all sort of.
Absolutely.
That was really what I was asking.
Yeah, like from a family's perspective, like they just want the service, and all that coordination happens on the back end.
Okay.
Yeah.
And that's a public health department managed system?
No, that's managed by LA Best
LABDN.
Babies Network. It's funded by First 5LA.
All right, and the two public agencies are?
Yeah, so on LA Best Babies Network end, we manage, we build, we audit, do all the CQI for the database. Doesn't matter who's funded by who. Everybody gets the same, if you will, the service. So it doesn't matter who the funder is, but the whole point is, that's the whole coordination thing. So as Dr. Batra said, when a family sees someone from HFA, it doesn't matter if you're funded by First 5 or DPH or DPSS, they're getting the exact same thing. That staff member went through the same exact workforce development, training, we all have the same protocols, and so on and so forth. And again, the nice thing is when you have multiple funding sources coming into the same agency, on the back end, the agency also puts in a lot of effort to make sure that family is in the right place. So maybe they need to be on the CalWorks side. Maybe it's best if they're on the First 5 side for eligibility requirements or things like that. But it can all happen on the same data system because it's both a case management system, a monitoring system, and a referral system.
Wow, I wish we had that for other parts of our county government, right? Having that common data system is so valuable.
I just want to add a little bit to that. It's even deeper than you've heard here, because, and Deanna and Charlene are going to have to help me with the years, but we created a countywide, yes, thank you. We created a countywide system. So we have a home visiting system that is LA countywide in 2017.
The e-directory.
Yeah, and a board motion that asked for us to work together and figure out how we can make home visiting more understandable, more approachable, et cetera. Consortium that's been in place for
11 years.
13, 14 years at this point, and that the database includes more than just the 3 programs we've been talking about. Because there are other home visiting programs that are funded separately or funded in a different way, and so wanting to make sure that the database that they have, that you can look up online and say, where are home visiting programs in my, although very few families actually do that. It's just that it's been very, very purposeful. And I was just saying to Charlene before, and from my point of view, having been around before all that happened, very effective.
I appreciate you bringing up the e-directory. I think that one's a really important community and county resource because it also, it includes every home visiting model in the county. It is not just HFA PAT. It includes early Head Starts, Healthy Start, PFF. It includes NFP. It includes some homegrown programs, all in there. And what it is also, it's an opportunity for a family who wants home visiting, goes in there and answers a few questions and automatically gets a referral. And they can get in touch with local resources based off of their eligibility, and they can be connected right then and there.
Thanks so much, that's great.
Thank you. Any other questions? I do have a question that's, you'd mentioned that with two of these programs, they're targeted. Welcome Baby is universal. If, as we're having this conversation and we get into some of the questions that we're going to get into, if we're unable to sustain a universal model for Welcome Baby and it does become targeted, what would you all recommend that sort of looks like as a way of reaching groups that are not necessarily reachable because they don't qualify for HFA or PAT. They're not high risk in the sense of being a part of like CalWORKS or on Medi-Cal, but they're a reasonably stable family. So a Black family, a Black mother who is married, has a home, is college educated, is still at a higher risk for infant or maternal mortality, but they don't qualify for these more intensive programs. And if we move from Welcome Baby to a more targeted universalism, what could that look like? How do we define services that are for those folks who need to be reached and need to be supported to have a healthy birth, to reach our strategic goals, but they don't qualify based on these usual factors for eligibility?
I can so I think Dr. Franklin can also speak to this, but we have so the nice thing about having multiple, so there's the CalWORKS, and that's definitely our biggest funder, our largest funders sort of are tailored to the populations you mentioned. However, we turn no one away, and so we do have funding from I think California Home Visiting Program, other sources that are free, is that a little bit of county dollars that are unrestricted, so we wouldn't turn anyone away. Okay. We're talking about home visitation, capital H, capital V today, but there's also, we have a Black infant health program that's for, open to everyone. We have we have other we have group care, group prenatal care. So we have other things that are, this is one of our most intensive, I think, and structured interventions, but we have kind of the range to serve anyone, if that makes sense. So to that family, that mom today would leave with a program.
Okay, thank you.
I don't know if you want to add to that. I think that's correct.
And I think you covered it, especially if we're talking about a program that's 2 or 3 years. If a family came in and they do not qualify or aren't eligible for CalWORKS, we would immediately look at California Home Visiting Program, which can receive any family, and includes the same sites that First 5 LA funds for HFA and PAT. And then, one thing that we know about addressing birth disparity, it's not one intervention that is important, right? We would connect them with the doula program. We definitely ask them about Black Infant Health Program if they have interest in that as well.
Okay, thank you.
I think one of the unique things about Welcome Baby in particular is because it's in the hospital. And I think that's where the success has been in the catchment of enrollments of families. I think what, in my opinion, also what we've seen is we need both, in my opinion. I think we have families that have first-time parent, there's some stress, there's some anxiety, breastfeeding, I need to figure out some stuff with the pediatrician, I need to do this and that, which Welcome Baby was initially designed for, again, the light touch universal model. And then I think also, 15 years doing this, you build that relationship with that family and all of a sudden all the other stuff comes out. I don't think we've engaged with a family at this point that doesn't have at least one adverse childhood experience in terms of the parent. And we are also now going through a whole other range or generation of children that already have ACEs just because of the generation they were born in, right? So my opinion is if you can have that, if you have that program that assesses you, and then the whole point is to get the family to the best fit program. So if it is the long-term, more intensive program, perfect, let's make sure they get there. But it takes time to also build that relationship, to convince a family that, hey, are you okay with someone coming into your home weekly for the next 3 to 5 years? Someone asked me that question, I'd be hesitant. So I think it's the balance of understanding the value of both and recognizing that in a community this diverse in LA, I want to be really specific about Los Angeles County, is there's value in having both these systems, and the beauty of it is the collaboration already exists. We've spent 15 years working on it. So whether it's Welcome Baby finding a family prenatally and sending them to NFP, because that's the best fit for the family, or it's they're DCFS involved, we know we need to get them into an HFA program that has that clause with HFA national model and so on and so forth, or if it's a PFF family that we need to engage with and so on and so forth. But but I also recognize there's money involved, right? So it's, as Dr. Batra said, these are very expensive programs. And how do we find that fine balance between, I guess, reach and dosage? While taking into account that these are numbers, but these are families, they're humans with stories. How can we do the best we can with each one we encounter?
Thank you. I think that's a great segue for the board questions that we have on the last slide. So I want to thank you, Dr. Batra, for your presentation and for all of you answering our questions. In the red box, there are some questions on the bottom. The first one says, given First 5 LA's declining revenues, what strategic priorities should guide home visiting investments to have the greatest impact in addressing the conditions and needs families are navigating? And then the second one, because it is small, says, what evidence would give the board confidence that our home visiting investment is producing meaningful impact for families and influencing systems over time? And so I've been told that there is a request for the commissioners, for the board, to give direction on these answers, or answers to these questions. And so I'm just taking that first question, given First 5 LA's declining revenues, and what you just said, Dr. Gonzalians, is that this has been a program these programs have been built over 15 years. So there's already been significant investment for all three programs, almost $500 million. We're not able to fund them at that level anymore. But we've also heard that it is undoubtedly important, critical work that's being done for the community. So how do we take the declining revenue that we have and still maximize it so that we're meeting these needs and then reaching more people? So just that first question is being posed, and they're requesting information from us. So given First 5 LA's declining revenues, what strategic priorities should guide home visiting investments, and that's home visiting capital HV, to have the greatest impact in addressing the conditions and needs families are navigating? Do commissioners have thoughts on that?
Can I also add a nuance, because I know folks will be walking out soon. I know time's almost up. It would be really helpful to also hear 5 years from now, we're going to sit at this dais, and what would you need to hear for us to say, yes, the impact of this change. Dr. Batra gave us outcomes that are really long-term outcomes. And then, Commissioner, you've shared also from LA City, here's housing and connection impacts. That's what we really need from the board. 5 years from now, when we're sitting here, what do you need to hear from us to show that this program had impact? And then we'll take that back for design.
And I know you all have ideas. Commissioner Byrd.
So one thing I would like to hear, I love how you reframed it, 5 years from now, because then I can think very easily, this is what I would want to see. Here's how the program pivoted a little bit to be more inclusive of these higher risk communities, right? Here's how we partnered with maybe promotores or a parent partner to connect with that family who initially said no, to change that no into a yes, right? Or here's how we brought in graduates of the program to actually work with us and bring that person in earlier.
It's really helpful. Commissioner Cortez, I saw your hand.
I was just going to have a suggestion, and this sounds a little crazy, so bear with me. I really appreciated every page having a deep dive into every program, and I was just wondering how many families are approached by all of the different entities and get really overwhelmed and just keep saying no. So I was wondering if there is a possibility, even if it's front and back, of like an infographic that shows who goes where and why and how. Because I think that would be that would help me, right? And even though I'm a few years into this, I'm still trying to navigate this and understand. But just sort of like having what are the buckets and where do they go? Because I think and it also really helps us, but also you all, because when you go to ask for funding from other sources, this is all really kind of feels overwhelming again for families to try to figure out who goes where and why. And as you mentioned, they're really expensive and, all those things. So that was one suggestion I had, and I'm sorry, I should have said that before. But to answer that question, though, I'm going to go back to that school readiness piece, because I think that's where a lot of people care about. I care about it too, but I really care about I don't just care about are they ready for school, but when they get to that age 4 or 5 and they're starting UTK or kindergarten, are they going to be able to socially integrate with other kids? That's what I care about. I care about, are they going to be sent to the principal's office or not, right? Which we don't want them to do, but, and specifically our really high-risk families, right, that typically do go to the principal's office more often than other groups. So I really want to pinpoint that piece of how do we show that they are able to socially integrate and thrive in school. Or where they go next. And then I guess if there was a 10-year goal or 15-year goal is are we getting kids to go on to their next venture, right? Are they going on to high school? Are they going on to community college? Are they going on to college? Are they getting a job? So I know that nobody asked for that, but I'm thinking, and I think about the Perry Preschool Project and the Abbottitarian Project, where there were really great long-term outcomes, but they were preschool-based. But right, for our really young babies, what are the kind of the short-term, integrating into school, thriving, being academically ready, but also socially able to work with people. And then I guess the other pieces were there were somewhat large gaps in the orange outlines in some of the areas that seem to be maybe more high need, like Pasadena. I can't think off the top of my head. There was another. West LA. So maybe kind of having more funding towards those specific areas that seem to be high need and that we can reach more families. Thank you.
Thank you. Commissioner?
I'm sorry, I'm going to have to leave promptly, so I just want to get mine in real quick. I sort of agree and sort of disagree with Dr. Byrd, all in a friendly way. I think the things he called out are important, but they're the process kinds of measures that Dr. Badra talked about. I really am interested in outcome measures, and in 5 years, I feel like there's time to have outcome measures. How many door knocks did we do? How many times did we attempt engagement? How many pamphlets did we hand out? And I'm not denigrating those things. All those process things are probably less important to me on a longer time frame than how many kids ended up in the child welfare system. What did infant mortality look like in the other kinds of things that public health listed up? I mean, I think that's really the proof of all those strategies and processes making a difference. And then second thing, I still love that we're founding our work on the equity index. I want to hear what moved in those dark purple areas. In the deep purple, what happened there? Because we're saying as a board, we are prioritizing and valuing those vulnerable populations more. So I'd want to know, so what did we do? Like we've said the words, did we put our treasure, our resources, our energies into making that real? In 5 years, did we really do it, or was it just performative language? All right, sorry, I'm going to have to run.
Yeah, and I'll say my thoughts are kind of a combination of both of yours, because I think the process and the outcomes are both important, because when it comes to Black families, especially who don't feel a connection to these systems and don't access them at the rates that they should, they're also the highest number of, they make up one of the highest percentages of families who are system involved, whose kids do end up as a part of the system because of maybe that touch point that they rejected for fear that this self-fulfilled prophecy was going to happen. So I think it's really a little bit more complicated than that. And so my request, if I could see this 5 years from now, it would be not just the social implications or like the typical social determinants of health that determine if someone is eligible for the program. And I really appreciate you both saying earlier that there is no rejection. Like we will find a way to support you. However, if the message is not reaching the targeted population and I, a married woman who was college educated, having a baby, don't think that I qualify, I'm not even going to consider it. But if you ask me a question like, did you feel heard during your birthing experience? Did you experience racism? Do you feel like you experienced microaggressions when you visited your medical care center? I would have absolutely said yes. And I was never, after birthing multiple babies, I've never been asked any of those questions. And I would have told you later on that by not being listened to, one of my children ended up in the NICU because my water broke and they didn't believe me. And that is so common. And so if we're not asking these questions, who's engaging with the birthing person? What questions are being asked? And is it just this objective list of like your income, your zip code, if you're receiving Medi-Cal, then we're still going to lose these populations of people that don't feel heard and seen because the system doesn't see and hear them. And so I would like to see more of those lived experiences being factored into who's eligible for the services and how they're supported. So, Commissioner Marquez.
Thank you. I just wanted to double down on that. I think you said it perfectly. I can't even try to say it as eloquently as you did, but I think like when I think about the equity lens that we're applying, I would like to see a different strategy on how we're going to engage Black families, because I do think that irrespective of the neighborhoods, there is a gap there that we do need to address. And so I agree that those questions need to be go deeper and reframed, because I think the model, and it's not a criticism, I think that we do it often, and especially in just looking at our same processes. So that's one. I would like to see a more robust strategy to engage Black families. And then the other was just what are we doing to remove the barriers for parents, whether it's a single parent or a two-parent household? Because yes, it's important absolutely to focus on the well-being of the child, but I do think that the two go hand in hand. And so if a parent is stable, then the likelihood of the child having a better outcome is higher. And so I don't expect that we address and solve for all of the challenges that families may have, but I do want to have deeper connections to, again, system alignment, resource alignment. We know that there's gaps, so what can we do as system leaders to try to fill and address those gaps? That's what I would like to see.
Commissioner.
Thank you. I just wanted to add to that it's extremely important that the data that we're gathering, especially about systemic racism or families that are not being serviced in the same way as others, we need to get that data out, because I think that your services are so important that not only are you helping the families that you work with, but with the data that you have, and when you frame it in that context, it can really begin to be a change agent. So I really applaud the work that you've done, and I know what we are thinking about is how to make that stop happening, so that we have families and mothers especially that can go in and be treated in the same kind of a way. I had the same experience as you. So, it's people of color. And I was losing my baby and they didn't believe me. And so, you go in and you don't really have that treatment. So I think that, again, the racism is still strongly there. Yeah. And so I think that, again, I want to applaud the work that you've done, and maybe we can find some ways of maximizing that work by getting the information out.
Thank you for sharing that. Are there other thoughts? And I do think that calling out these things, whether it's sexism, classism, racism, naming it when interfacing with families might actually lead them to seeing that, oh, you might be a government agency or government funded, but you're not the enemy. You're not the agent of the harm, because that's how sometimes folks see government institutions as the agent of harm. And especially in a climate like this right now, it's hard to separate the two. Even with our declining funding, people are seeing the cuts being made at this level, even though we're being very intentional and thoughtful about it, but they can't separate that from what HR 1 is violently doing to communities. And so I think us being willing to name these things might help bring more folks in who feel safer saying, I can trust this because they know that I need to feel seen as a person. So thank you. Are there any other comments or questions? I do want to, we have 3. Oh, okay. 1 second. Yep. Yes, can you? Yep. Yeah, that would be great. Thank you.
So we're coming back with some input from you all. You have heard the sort of mix of hospitals, community-based organizations, and government. Any insights from the board in regards to really important aspects of the program to consider as we think about that mix? Right now, we have heard from the team that all of it is important, and I just want to hear from the board before opening it up on what would be critical for you all to consider as we think about the options we will bring back.
So one of the things that was presented last month by Orange County was that they had brought some of those services in-house and were claiming to Medi-Cal. They had found out the secret in that sauce. I think getting that information, how that was done, how they were able to do that, could go a distance in leveraging existing funds. I mean, your Prop $10 because it's state could be a local match to draw down federal dollars for Medi-Cal. So I think that looking at it that way may be a way to sustain a program and be here in 5 years realizing these gains.
I think that's a really good idea because I was talking earlier just about Family First funds that are going to be available for community-based organizations that are engaging in the kind of exactly the evidence-based practices that everyone's been talking about today. And your state dollars are the matching funds. That's always, frankly, one of the big barriers for any organization. And same with, I was thinking about CalAIM and ECM. Is that the acronym? Is it ECM? Yeah, and I mean, you may know the answer to this, but it just feels like, these should be Medi-Cal eligible services for certain populations if we have already the approval that we are a Medi-Cal provider or that we are a Medi-Cal certified biller.
Easy to say, hard to do, because you are a Medi-Cal contract. So we're doing it on a small scale. You have to it's quite a high burden for a community-based organization. But yes, it is possible.
Right, but for like a First 5 LA, could you become kind of help them by being the biller? Like you could
possibly.
be at the top of the pyramid.
That's how it would work.
Or Best Babies. I don't know. I mean, like one of the larger organizations that are managing the training and use of these services. You're possibly better equipped than a small community-based organization. In essence, you're helping them access those Medi-Cal dollars.
And Orange County First 5 has a model.
I mean, those federal entitlement dollars are really like one of the only things left. There's no program dollars, right? So it is a heavy lift, but it isn't impossible. It's like you said, Orange County's doing it. So.
So earlier, I think Commissioner Segala mentioned the anecdotal piece and how a lot of us really appreciated hearing kind of some like bits and pieces of what anecdotally is helpful. I wonder if possibly somehow being able to survey or interview current or past families to kind of really hear sort of what are the, if we're thinking about narrowing our focus, I think for a long-term financial plan and endorsement, I think maybe having those kind of voices to really hear, what have been the biggest outcomes for families? What did they really appreciate about the program? What were the, I'm not sure if I'm being really clear, but does that make sense what I'm hearing, what I'm saying?
It does. Luckily, we already have client satisfaction surveys. We have family videos. We've got tons of those. Our team sitting in the back just collected a whole bunch from the families that were here last month as well.
Amazing.
So anecdotally, we've got the stories of families. They're open-ended questions, right?
Sure.
If there's a specific question that's a little bit different, but I know each one of these models also require client satisfaction surveys. For HFA and PAT, they're discussed every quarter during their community advisory board meeting. On the Welcome Baby side, they're discussed quarterly and dispersed. They've got the dashboards and everything, all of that.
So I guess for me, it would be like, once that you've collected all that data, but then kind of figuring out which buckets they go into and how those align with our strategic plan. And then I think when we present, at least for me, when you present it to the board, I think it's sort of about kind of making the big the small, if that makes sense. And so, you hear here's an anecdote about, I don't know, this family and how impactful this part of this program was, or that program. And I think that sort of really speaks to a lot of us, because we're not on the ground doing this work, but you all are, and we trust you all, of course. But I think that really helps me to kind of be like, oh, that makes sense, or oh, this piece was the most important part. So I think maybe kind of having that, or even testimonials from those folks themselves, videos or in person. So those are the things that, for me, that kind of make sense and that really help. Thank you.
So I'm in a lot of conversations these days about no wrong door. It's sort of all over the place, no wrong door. But if we could, in 5 years, get to a point where there weren't 3 approved or 6 approved places where you go when you're interested in getting help with your pregnancy or your newborn baby, if there were no wrong door for families, I think that would teach us really a lot about who goes where and how do we break down the stereotypes, right? I know LA is a really big place, and it's hard to even think about that. But some people are not going to be comfortable at a hospital inviting, more people to get into their business. And some people, so et cetera, et cetera. So we've just got to think about, where do families go and where do families feel good? There's no single answer to that. It's CBOs and hospitals and, et cetera, et cetera, et cetera. And trying to think about that seriously, what would that mean? It doesn't mean sending families around to 10 different places, right? It means the organizations collaborating to assure that whatever works best or is most comfortable for this family, we can work together to achieve that.
I'm thinking of a conversation for another time, but as we move to a hub model, what role does that play in helping be a navigator in these spaces? And can that be the door that's never wrong?
Yeah, I was just going to add to that point. I think where we will see success in 5 years is how are we bringing in partners who can sustain parts of this work, as the larger entity just can't do it all. Mm-hmm. There are plenty of organizations, ones we could think of in LA County, that do something in alignment with this, and if we give them the capacity and the on-ramp to be able to support pieces of it, not large entity parts of it, but pieces of it, I think that we can see some stability within it. And I think it's also important to look at the fact that we have to think about what is, and this is more of emphasizing a point, what is it that folks are really in need of? And really focusing our attention to those things. So I appreciate the comment around how do we draw from what participants are saying are what they most need, and let's focus on that first, on top of the lens of the equity index, and really target and drill down to those specific communities, because I think that's how we're able to find those access points for people who are in need. And then I'd say I always just want to throw it out there that, you know, a great pathway as these families are in need of trusted messengers, we have to look at our community-based organizations, other entities that are in the community each and every day to make sure that we're driving more intentional enrollments of not only just Black communities, but I even think about our indigenous, Native, and indigenous communities as well, and all of our communities that are experiencing disparities. They don't go to all community-based organizations, and I say that has a fiance who's Native American. So I just think we have to consider those things as well, right? So, you know.
That's good. All right. I think you all have been really helpful. That's what Carlos said. So. Thank you for your input, everyone. Are there any final thoughts or questions? Because I know we do have public comment, correct? All right. I want to give an opportunity for public comment. Thank you for bearing with us through the time. Ms. Vo, do we have public comment in the room?
Confirming that we do have 3 public comments, and as I call your name, you will be allotted 1 minute. And I'll start with Teresa Garcia Lays will be the first one, Steve Nish is the second, and Rachel Aguilar is the third. Okay. Thank you.
Hello, Steve actually had to go.
Could you?
So we just had 2 members leave, so unfortunately it's just me. My name is Rachel Aguilar, and I am the program director of the Welcome Baby at Emanate Health. And I really do appreciate and acknowledge that it's tough decisions you all have to make. And I do appreciate the curiosity and the questions that are being asked today. I want to keep it sweet since I only have 1 minute, but I understand the difficulty in how expensive the Welcome Baby program is, and I acknowledge that. And I think as a program and as a grantee, my goal has never been that First Five is going to sustain the program forever. We know that it's a very expensive program. What I am asking is for an opportunity to become evidence-based. That would be very helpful for us to be able to apply for state and federal grant funding opportunities that at this point we have not been able to tackle. HFA and PAP programs are evidence-based models, and they can apply and have received those grant funding opportunities, but for us, we haven't been able to do that. Oh, thank you.
Enough for the sound. Thank you so much. So there are no other public comments in person?
There are no other ones. I believe the other 2 just left.
And do we have are we taking any public comments from online?
We don't have any public comments online. I do have some emailed, and I will ensure that the board receives them after the meeting, because there are some attachments too, and that way you can receive a complete package.
Okay, perfect. Thank you so much, Ms. Vo. I'm looking back at my notes. That was the last presentation. I just want to thank you all for your time and for us to be able to continue this conversation into this meeting, and for everyone staying later. If there's nothing else, maybe
I do want to confirm, Madam Vice Chair, that there are no general public comments.
Okay.
For the record, thank you.
Okay, thank you so much. No comments for items not on the agenda or general comments. We are now adjourned at 4:48. Thank you so much, everyone.